Sights and Sounds in Ophthalmology, Volume 3, The Ocular Fundus in Neuro-Ophthalmologic Diagnosis, a slide tape presentation from the Neuro-Ophthalmology Unit and the Retinal Vascular Center, the Wilmer Ophthalmological Institute. Introduction. We begin with a detailed study of the ophthalmoscopic appearance and histologic architecture of the normal optic nerve. Slide 1. The normal optic nerve. Upper left. The normal optic disc is a well-defined, round, or vertically oval disc with a pinkish-yellow tint. The nasal portion of the disc may be slightly deeper in color than the temporal portion. The retinal vessels emerge from the center or just nasal to the center of the disc. In most normal eyes, the optic disc has a central depression or cup. The cup is generally circular, and while the area of the cup often does not exceed 30% of the total disc area, cups that occupy up to 80% of the total area may be observed in normal eyes. The boundaries of the optic disc are generally distinct, owing to the relative transparency of the peripapillary retinal nerve fiber layer, through which one can see the termination of retinal pigment epithelium at the border of the disc. The normal peripapillary retinal nerve fiber layer appears slightly opaque, with a radially oriented, finely striated pattern of superficial light reflexes. Opacity of the layer is greatest where the arcuate bundles enter the disc superiorly and inferiorly, since more fibers enter the disc in these areas. Nerve fiber reflexes can be appreciated on the nasal side of the disc, but they are difficult to see on the temporal side because of the finer caliber of axons in the papillomacular bundle. Nevertheless, in a patient with a normal optic disc, the striations of the peripapillary retinal nerve fiber layer can be followed to the disc margin for 360 degrees. Upper right. This longitudinal section of a normal optic nerve shows that the nerve is composed of longitudinally arranged nerve fiber bundles, separated by fibrovascular peel septi. The gray staining area represents myelinated nerve fibers. Myelination of the anterior visual system begins at the lateral geniculate body and ordinarily stops at the lamina cribrosa. The lighter staining area of the optic nerve anterior to the lamina cribrosa is the optic disc. Lower left. A cross-section of the normal optic nerve shows that it is invested by three sheaths. The dura, a dense collagenous tissue continuous anteriorly with the sclera. The arachnoid, a more cellular tissue having relatively few collagenous fibers and blood vessels. And the pia, the most vascular of the meninges, and the only tunic that is firmly attached to the nerve. Peel extensions into the nerve subdivide it into longitudinally arranged compartments through which the nerve fiber bundles course. Lower right. An artist's sketch illustrates peel extensions surrounding the nerve fiber bundles. Blood vessels within the peel septi supply the nerve fibers. Slide 2. Blood supply of the optic nerve. An artist's sketch illustrates that the blood supply to the prelaminar optic nerve is controversial. The left side of the slide illustrates the theory that the major afferent blood supply to the optic disc arises from choroidal vessels. The right side of the slide illustrates a second theory, that short posterior ciliary arteries pierce the optic nerve behind the globe to supply the optic disc directly. According to this theory, direct choroidal contribution to the prelaminar portion of the optic nerve is minimal. The major blood supply of the retrolaminar optic nerve is derived from the ophthalmic artery, including branches from peel vessels and intraneural branches of the central retinal artery. There are also anastomoses with meningeal branches of the external carotid artery. Slide 3. The normal optic disc. This 34-year-old male has a normal eye examination. Upper left. The disc is pink with a small, round central cup. Its margin is well defined. Superficial disc vessels and peripapillary retinal nerve fiber layer striations are clearly visible. Upper right. A red-free photograph at 2x magnification shows the fine striations of the normal peripapillary retinal nerve fiber layer. Lower left. A fluorescein angiogram shows normal filling of retinal vessels and no leakage from disc capillaries. Since these superficial capillaries are branches of the central retinal artery, their endothelial cells have tight junctions that do not permit the passage of free fluorescein molecules. Lower right. A fluorescein angiogram shows late staining of the optic disc. This normal finding presumably results when fluorescein dye molecules from fenestrated peripapillary choroidal capillaries leak into optic disc tissue. Slide 4. Normal variations of the optic cup. Although most cups occupy only 30 to 40% of the disc area, large cups comprising 80 to 90% of the disc area may be observed as a normal variation in patients who have no evidence of glaucoma. Upper left and upper right. This 24-year-old male with normal visual acuity and fields has pink optic discs with well-defined margins and small central cups that occupy less than 10% of the total disc area. Lower left and lower right. This 26-year-old male also has normal visual acuity and color vision, full visual fields, and consistently normal intraocular pressures. Both optic discs are normal in size, but the cups are large and circular and occupy approximately 80% of the total disc area. In each eye, a good temporal rim is present, and the peripapillary retinal nerve fiber layer is normal. We now leave the normal optic disc and begin our discussion of the pathologic disc. In evaluating the optic disc, the clinician is constantly faced with two major problems. Number one, how to differentiate true optic disc edema from elevation of the disc caused by a congenital anomaly, and two, how to determine the etiology of optic disc edema. In the next section, we discuss various causes of optic disc edema and the methods used to differentiate among them. Slide 5. Papilledema and increased intracranial pressure. Upper left. This optic disc from a patient with increased intracranial pressure shows marked edema and hyperemia, or papilledema. Upper right. A longitudinal section from an eye with papilledema shows marked elevation of the optic disc. Anterior to the lamina cribrosa, the nerve fibers are swollen and somewhat pale. The peripapillary retina is elevated and pushed laterally. Lower left. The artist's sketch shows the normal flow of cerebrospinal fluid. Fluid is produced in both lateral ventricles and in the third ventricle. It flows through the aqueduct of Sylvius to the fourth ventricle and down the central canal of the spinal cord. The cerebrospinal fluid then flows around the cord and back up through the foramen magnum, over the cerebral hemispheres, and is finally absorbed through the arachnoid villi into the cerebral venous drainage system. Most cases of increased intracranial pressure are caused by one of three mechanisms, as illustrated by the artist's sketch lower right. Number one, the ventricular system may be blocked directly by congenital lesions, as in aqueductal stenosis. Number two, the ventricular system may also be blocked directly by acquired lesions, such as tumors or subarachnoid hemorrhage. Number three, cerebrospinal fluid absorption through the arachnoid villi can be obstructed either by direct blockage of the villi, by blood or protein, or by obstruction of the cerebral venous drainage system. A rare cause of intracranial pressure is increased cerebrospinal fluid production, as in choroid plexus tumors. Slide 6. Axoplasmic transport in papilledema. Papilledema is defined as swelling of the optic disc, and in this sense has been used to signify optic disc edema from any cause. However, because of its connotation to most neurologists and neurosurgeons, the term papilledema should only be used to describe optic disc edema caused by increased intracranial pressure. The role of axoplasmic transport in the pathogenesis of papilledema is currently under investigation. All nerves, including the optic nerve, have long extensions called axons that lack the ability to synthesize protein. The protein necessary for axon survival is synthesized in the nerve cell body and reaches the axon by a specialized form of cytoplasmic motility called axoplasmic transport or axoplasmic flow. Upper left. The artist's sketch shows that the nerve may be thought of as a tube through which there is a continuous flow of cytoplasm from the nerve cell body to the end of the axon. Proteins are synthesized in the cell body and are carried to all parts of the axon in this manner. Upper right. The artist's sketch of the optic nerve shows that axoplasm flows from the retinal ganglion cell through the optic disc, past the lamina cribrosa, and through the retrolaminar optic nerve to stop eventually at the lateral geniculate bodies. To shed light on the pathogenesis of papilledema, Minkler and co-workers studied obstruction of axoplasmic transport in the optic nerve in experimentally increased intracranial pressure. Lower left and lower right. A phase contrast photomicrograph and an artist's sketch show that following production of experimentally increased intracranial pressure, labeled protein remains in the prelaminar portion of the optic nerve and appears to be blocked at the level of the lamina cribrosa. Although the pathophysiology of papilledema is associated with obstruction of axoplasmic transport, it is unclear whether the obstruction is a primary event or is simply a secondary phenomenon common to all forms of optic disc edema and independent of the specific pathogenesis. We now discuss some case histories of patients with optic disc edema from various causes. Slide 7. Papilledema and metastatic tumor. This 57-year-old female noted an enlarging mole on her shoulder. Biopsy revealed malignant melanoma. The patient became progressively lethargic and complained of headaches and intermittent blurred vision. Visual acuity was 20/20 bilaterally, color vision and pupils were normal, and visual fields showed enlarged blind spots. Upper left and upper right. The optic discs are markedly elevated, edematous, and hyperemic. There are superficial hemorrhages. The central retinal vessels are obscured as they pass through the edematous disc tissue. Lower left. Computerized tomography, or EMI scan, shows two dense lesions in the right frontal and right occipital lobes. The surrounding lucent zones probably represent cerebral edema. Lower right. A second EMI scan, taken at a different level, shows a left frontal lobe lesion. Other cuts showed a total of 7 distinct intracerebral masses. Biopsy established a diagnosis of metastatic intracranial malignant melanoma. This patient demonstrates the classical ocular findings in papilledema. Visual acuity is typically unimpaired unless there are exudates or hemorrhages extending into the macula. Color vision is normal. There are no pupillary abnormalities. Visual fields show variable enlargement of the blind spots. It is this clinical ocular picture, often associated with other signs and symptoms of increased intracranial pressure, such as lethargy, headache, nausea, vomiting, sixth nerve palsy, and ataxia, that is of major importance in differentiating papilledema from other forms of optic disc edema. Patients with papilledema should always be presumed to have an intracranial mass until proven otherwise, and should be hospitalized immediately so that the etiology of the increased intracranial pressure can be ascertained and appropriate management instituted without delay. Evaluation of such patients generally includes one or more of the following procedures: skull X-rays, computerized tomography, cerebral arteriography, and pneumoencephalography. Slide 8. Papilledema and posterior fossa tumor. This 12-year-old female experienced the gradual onset of headache, nausea, and vomiting. A neurologist found severe ataxia, a right sixth nerve palsy, and bilateral optic disc edema. Visual acuity was 20/20 OU, color vision was normal, and visual fields showed enlarged blind spots. Upper left. The right optic disc is edematous and elevated, with loss of the normal margin and blurring of the peripapillary nerve fiber layer. The left optic disc had a similar appearance. Upper right. An EMI scan shows a large, well-circumscribed, cystic mass in the posterior fossa. Lower left. An EMI scan slightly below the plane of section shown above demonstrates a small, solid mass attached to the inner wall of the cyst. At craniotomy, this proved to be a cystic astrocytoma with a mural nodule. The nodule was excised and the cyst was drained. Lower right, 10 months postoperatively, there is marked regression of the optic disc edema and no evidence of optic atrophy. Visual acuity is 20/20 OU with normal visual fields. This case exemplifies one of the primary causes of papilledema, a posterior fossa mass lesion. In childhood, most tumors that cause papilledema are located in the posterior fossa. Of these, the cystic cerebellar astrocytomas are potentially curable by drainage of the cyst cavity and removal of the mural nodule that is almost always present. Slide 9. Papilledema and frontal lobe tumor. The family of this 47-year-old female noted a change in her personality over a 6-month period. She had become forgetful and sloppy in her appearance. There were no focal neurologic findings, but the mental status examination suggested a frontal lobe disturbance, and she was hospitalized for further evaluation. Visual acuity was 20/20 OU, and visual fields were full. Upper left. The right optic disc is mildly hyperemic. The disc margin is indistinct. Over the next 24 hours, the patient became lethargic. Upper right is a photograph taken 24 hours later, showing fully developed optic disc edema with a flame-shaped hemorrhage crossing the disc margin. Lower left. An ME scan demonstrates a large mass in the left frontal lobe with a marked left-to-right shift of the midline. Lower right. 6 months after removal of a large meningioma, the right optic disc appears normal. Comparison of the upper left and the lower right photographs clarifies the findings in early optic disc edema. Typically, early disc edema is characterized by hyperemia, mild blurring of the peripapillary retinal nerve fiber layer, an indistinct margin, and slight dilatation of the retinal veins. Venous pulsations may be present or absent. Small, superficial, flame-shaped hemorrhages may be seen at the disc margin. Fluorescein angiography during the early stage of disc edema often, but not always, shows leakage from the disc capillaries. Cerebral tumors cause increased intracranial pressure and papilledema much less frequently than tumors of the posterior fossa, but may do so by deflection of the falx cerebri and pressure on the great vein of Galen. Not all patients with papilledema have intracranial masses, however, and we now turn our attention to the syndrome of benign intracranial hypertension, or pseudotumor cerebri. Slide 10. Pseudotumor cerebri treated with steroids. This 28-year-old female had complained of headaches for 3 months and had recently noted trouble seeing in both eyes. Except for obesity, she was healthy and took no medications. Visual acuity was 20/40 right eye and 20/50 left eye. Color vision was slightly diminished bilaterally, and pupils were normal. Visual fields were full peripherally with enlarged blind spots. Upper left and upper right. The optic discs are so hyperemic and edematous that no true disc is discernible. Numerous hemorrhages and cotton wool spots surround each disc, and a macular star figure is seen in each eye due to lipid accumulation in the outer plexiform layer of the retina. The neurologic examination was normal. Cerebral angiography and pneumoencephalography failed to demonstrate an intracranial mass. The ventricles were small. Lumbar puncture revealed an opening CSF pressure of 450 millimeters of water. A diagnosis of pseudotumor cerebri was made, and the patient was treated with systemic steroids for 5 months. Lower left and lower right. 6 months after completion of the course of steroids, the discs are normal, and the patient has no visual deficit. This patient typifies the pseudotumor cerebri syndrome of elevated intracranial pressure without an intracranial mass. The syndrome may be associated with a variety of toxic conditions, viral diseases, and endocrinologic disturbances, and is most common in obese young females in the third decade, although the age range is extremely broad. The most common symptoms are chronic headache, double vision, and transient disturbances in visual acuity. There are no localizing neurologic signs. Ocular findings include papilledema of varying severity and sixth nerve palsy. Cerebrospinal fluid protein is normal. The cause of pseudotumor cerebri is unknown. It may be due to an increase in CSF production or to a relative obstruction of CSF absorption across the arachnoid villi. Whatever the etiology, pseudotumor cerebri is a diagnosis of exclusion, although one may feel confident of the diagnosis in an otherwise healthy, obese young female with bilateral optic disc edema. Such a patient should always be assumed to have an intracranial mass until proven otherwise by computerized tomography and lumbar puncture or by cerebral arteriography and pneumoencephalography. After the diagnosis of pseudotumor cerebri is established, one must consider management. Although the condition is usually benign and self-limited, chronic headache or signs of optic nerve damage may necessitate treatment. The major difficulty in deciding when to begin any form of therapy is that one never knows at what stage the optic nerve has been irreversibly damaged. If one initiates treatment only after the first signs of optic nerve damage, the patient may progress to optic atrophy despite therapy. No matter what treatment is offered, 10% to 25% of patients develop some degree of visual deficit. This patient's symptoms and signs resolved after a course of systemic steroids. Whether this was due to the therapy is uncertain. Slide 11. Pseudotumor cerebri treated with phacoperitoneal shunt. This 54-year-old female was found to have bilateral optic disc edema during a routine eye examination. Visual acuity was 20/15 OU with normal color vision and full visual fields. She complained of mild headaches but had no focal neurologic findings. Upper left and upper right. The optic discs are edematous and hyperemic, and the retinal veins are dilated. There is a small hemorrhage inferior to the right disc. An ME scan revealed small lateral ventricles, and lumbar puncture showed an elevated cerebrospinal fluid pressure. A diagnosis of pseudotumor cerebri was made, and the patient was started on systemic steroids and followed for 6 months. Visual acuity and fields remained normal, but papilledema persisted, and the patient began to complain of transient obscurations of vision. Despite normal acuity and fields, she underwent phacoperitoneal shunt. Within 48 hours, the papilledema began to resolve, and the visual obscurations ceased. Lower left and lower right. 1 year later, visual acuity, visual fields, and optic discs are normal. A phacoperitoneal shunt was performed in this patient when she developed transient obscurations of vision with persistent headache and papilledema despite 6 months of systemic steroids. 3 procedures are available for patients with pseudotumor cerebri when fear of permanent visual damage is sufficient to warrant surgery. Phacoperitoneal shunt is effective but may be complicated by infection or obstruction of the shunt tubing. Subtemporal decompression is also effective but is less commonly employed. Direct decompression of the optic nerve by removing a small segment of optic nerve sheath within the orbit is a new procedure with promise. Evaluation of therapy for pseudotumor cerebri is difficult, since no one knows how to determine when irreversible damage of the optic nerve has occurred. For this reason, if a successful procedure is performed in a patient who has no objective signs of optic nerve damage, it is impossible to know whether the procedure has significantly altered the visual outcome. Moreover, if a procedure is performed in a patient with objective signs of optic nerve damage and the patient progresses to optic atrophy, it is impossible to know whether irreversible changes occurring prior to surgery precluded a successful visual result. This patient had a successful visual outcome after a shunt procedure. However, if no procedure had been performed, the outcome might have been the same. Slide 12. Pseudotumor cerebri progressing to optic atrophy. This 32-year-old male complained of severe bifrontal headaches for 3 months. Visual acuity was 20/20 OU, and visual fields showed enlarged blind spots. The rest of the eye examination was normal, except for bilateral optic disc edema. Upper left and lower left. The right and left optic discs are edematous, with indistinct margins. No hemorrhages or exudates are present. A neurologic evaluation was normal. Cerebral angiography showed no mass, and pneumoencephalography showed small ventricles, elevated cerebrospinal fluid pressure, and normal cerebrospinal fluid protein. A diagnosis of pseudotumor cerebri was made, and the patient was placed on steroid therapy for 6 months. Despite steroid treatment, the patient began to complain of transient visual obscurations, and the right eye visual acuity dropped to 20/40 with a constricted visual field. Upper center and lower center. After 6 months of steroid therapy, papilledema has become more severe. The optic disc capillaries are markedly dilated, and the larger retinal vessels are partially obscured by edematous disc tissue. Loss of visual acuity, worsening of papilledema, and the occurrence of transient obscurations of vision prompted subtemporal decompression. Upper right and lower right. After decompression, papilledema has resolved in both eyes. The right optic disc is pale and atrophic. The patient no longer has headaches, but visual acuity is 2400 right eye and 20/20 left eye with bilaterally constricted visual fields. This patient developed optic atrophy despite subtemporal decompression. The case emphasizes that once optic nerve damage is present, surgical decompression may fail to reverse the process, although it may serve to prevent further acuity and field loss in some patients. All patients previously discussed have had relatively symmetrical papilledema. However, asymmetric or unilateral papilledema may occur in patients with unilateral anomalous or atrophic optic discs and occasionally in patients with normal optic discs. Before we conclude our discussion of papilledema, we shall discuss the Foster-Kennedy and the pseudo-Foster-Kennedy syndromes. Slide 13. Foster-Kennedy syndrome from sphenoid ridge meningioma. This 44-year-old female noticed gradual loss of vision in her left eye. Visual acuity was 20/20 right eye and hand motions left eye. Visual fields were full on the right and constricted on the left. The neurologic evaluation was normal, except for anosmia on the left. Upper left. The right optic disc is elevated and edematous, but no hemorrhages or exudates are seen. Upper right. The left optic disc is diffusely pale, with generalized loss of the retinal nerve fiber layer. The retinal vessels are normal. Lower left. A skull X-ray shows hyperostosis of the left sphenoid ridge. Lower right. An EMI-scan demonstrates a dense mass in the left middle fossa. At craniotomy, this mass was found to be a sphenoid ridge meningioma that was directly compressing the left optic nerve and also causing a shift of the midline, with a secondary increase in intracranial pressure. This case represents a classic example of the so-called Foster-Kennedy syndrome, optic atrophy on one side with papilledema on the other due to a frontal lobe tumor. In the original description of the syndrome, the optic atrophy was ipsilateral to the tumor, but this is not a consistent finding. Although this phenomenon has received considerable notoriety, it is in fact exceedingly rare. Huber found no examples in his review of almost 300 frontal lobe tumors, although this patient did have a frontal mass that resulted in a true Foster-Kennedy syndrome, the most common cause of unilateral optic atrophy with contralateral optic disc edema is described in the next slide. Slide 14. Pseudo-Foster-Kennedy syndrome. This 54-year-old male developed sudden visual loss in the right eye. Subsequent evaluation disclosed right optic disc edema, mild diabetes mellitus, and hypertension. The patient was felt to have papilledema, and despite a normal neurologic examination, neuroradiologic studies, including pneumoencephalography, were performed and were normal. 3 months later, he noted visual loss in the left eye and was referred to the Wilmer Institute. Visual acuity was hand motions right eye and 20/30 left eye, with a right afferent pupillary defect and a constricted right visual field. Upper left. The right optic disc is atrophic. Peripapillary hemorrhages are presumably a residual from the acute episode 3 months previously. Upper right. The left optic disc is edematous and hyperemic, with hemorrhages predominantly along its superior aspect. Lower left. The visual field in the left eye shows an inferior nasal defect. This patient presented with optic atrophy on the right and optic disc edema on the left. The history of sudden visual loss combined with a visual field defect and a hyperemic edematous disc suggested a diagnosis of anterior ischemic optic neuropathy. A similar episode was undoubtedly responsible for the visual loss 3 months earlier. If the correct diagnosis had been made at that time, the patient might have been spared a neuroradiologic evaluation. Lower right. No treatment was recommended. The hemorrhages and disc edema cleared over several months. 1 year later, visual acuity left eye is 20/25 with a pale optic disc. The patient has been followed for 3 years and has had no further ocular symptoms or ophthalmoscopic changes. Dr. J. Lawton Smith has commented that once an acute episode of anterior ischemic optic neuropathy unrelated to giant cell arteritis resolves, he has never seen a recurrence in the same eye. Several points are worthy of repetition. Number 1. The term papilledema should be used only in dealing with optic disc edema presumed to be due to increased intracranial pressure. Use of the term to indicate all types of optic disc edema may lead to excessive neuroradiologic investigation, since, to the neurologist and neurosurgeon, the term papilledema is synonymous with increased intracranial pressure. Number 2. Despite the prominence of the term Foster-Kennedy syndrome, most cases with optic disc edema on one side and optic atrophy on the other are due to ischemia or inflammation, and not to tumor. Number 3. The clinical presentation of decreased visual acuity, defective color vision, and an altitudinal or arcuate visual field defect is not generally compatible with papilledema, but is typical of an ischemic or inflammatory process. Slide 15. Papilledema and subarachnoid hemorrhage. This 52-year-old female had the sudden onset of severe headache and stiff neck. At the time of initial examination, she was semi-comatose with poorly reactive pupils. Upper left. The right macula contains numerous intraretinal hemorrhages and a large subhyaloid hemorrhage. Upper right. The left optic disc is markedly edematous and is surrounded by subhyaloid hemorrhages. Cerebral angiography showed a right middle cerebral artery aneurysm that was clipped 2 weeks later when the patient's condition was stable. Lower left. 3 months later, the right macula is normal except for some minimal pigment epithelial changes. Lower right. 1.5 years later, the left optic disc is no longer edematous, but shows mild atrophic changes. Visual acuity is 20/20 right eye and 20/30 left eye, with mild constriction of the left visual field. Approximately 20% of patients with subarachnoid hemorrhage have retinal hemorrhages, vitreous hemorrhages, or both. The presence of retinal hemorrhages and optic disc edema in patients with subarachnoid hemorrhage is considered a poor prognostic sign. Hemorrhages may be intraretinal, subretinal, or subhyaloid, and are usually small and located near the disc margin. Pure vitreous hemorrhage with subarachnoid bleeding, or Terson's syndrome, is rare. Patients with the sudden onset of headache associated with multiple retinal hemorrhages and neurologic deficits should be considered to have subarachnoid hemorrhage until proven otherwise. Slide 16. optic disc edema, and hypertension. This 51-year-old female experienced the sudden onset of dizziness and blurred vision in both eyes. Visual acuity was 20/50 right eye and 20/30 left eye. The right visual field showed enlargement of the blind spot with a small central scotoma. Upper left. The right optic disc is edematous. Hard exudates are seen in the macula. Superficial hemorrhages and cotton wool spots are seen predominantly along the inferior temporal vein. Upper right. A fluorescein angiogram shows marked leakage on the optic disc and in the peripapillary retina. The patient's blood pressure was 240/160. The patient was initially treated with intravenous antihypertensive therapy and was then maintained on oral agents. Lower left and lower right. 6 weeks later, there is marked resolution of the retinal hemorrhages and the optic disc edema, but hard exudates persist in both eyes. The optic disc edema in severe hypertension with and without encephalopathy is usually not associated with increased intracranial pressure, and the term papilledema should not be used in this setting. The edema is probably due to local vascular changes associated with severe systemic hypertension. Slide 17, anterior ischemic optic neuropathy. This 54-year-old female noted sudden loss of vision in the left eye. The right eye was normal. The left eye had 24/100 visual acuity, defective color vision, an afferent pupillary defect, and a superior visual field defect. Upper left. The left optic disc is edematous. Superficial retinal hemorrhages and cotton wool spots are present. The patient had no systemic complaints, and her physical examination was normal, except for a blood pressure of 150/90. No treatment was recommended. Upper right. 3 months later, much of the optic disc edema has resolved, but the temporal disc margin is still indistinct and superficial capillaries are dilated. Lower left. 2 years after initial visual loss, there is pallor of the inferior temporal optic disc with loss of the peripapillary retinal nerve fiber layer. This area of pallor corresponds to a superior arcuate visual field defect seen lower right. This case demonstrates the classical presentation of anterior ischemic optic neuropathy: sudden visual loss, diminished color vision, an afferent pupillary defect, and an altitudinal or arcuate visual field defect. Anterior ischemic optic neuropathy may be associated with diabetes mellitus, hypertension, renal disease, or connective tissue disorders such as systemic lupus erythematosus. Nevertheless, the major association that one must consider in an older patient with anterior ischemic optic neuropathy is giant cell arteritis. In this patient, the lack of systemic complaints such as jaw, ear, or scalp pain, malaise, or weight loss, and an erythrocyte sedimentation rate of 12 effectively ruled out giant cell arteritis as a possibility. Treatment of patients with anterior ischemic optic neuropathy unassociated with giant cell arteritis is controversial. There is no convincing evidence that systemic steroids improve visual acuity or visual field. A randomized prospective trial evaluating the effectiveness of steroids in this condition is presently underway. At present, we do not advocate steroids for patients with anterior ischemic optic neuropathy unless the condition is associated with giant cell arteritis. Slide 18. Anterior ischemic optic neuropathy with giant cell arteritis. This 63-year-old female had noted fatigue, scalp tenderness, and pain on chewing for 3 months. 3 days prior to evaluation, she experienced the sudden onset of total blindness in her right eye. After a few seconds, some vision returned. Visual acuity was hand motions right eye and 20/20 left eye with a right afferent pupillary defect. Upper left. The right optic disc is elevated and edematous. Superficial hemorrhages are present inferiorly, and a large cotton wool spot is seen along the inferior temporal artery. The retinal veins are slightly dilated. An erythrocyte sedimentation rate was 60. The patient was started immediately on 80 milligrams of prednisone daily, and a right temporal artery biopsy was performed. Upper right. A histologic section through the right temporal artery demonstrates a chronic granulomatous inflammation constricting the lumen and involving all layers of the arterial wall as shown by arrows. Lower left, after 2 weeks of steroids, much of the disc edema has resolved and the disc is pale. The patient's systemic complaints resolved, but her visual acuity did not improve. Lower right. 4 months after the onset of visual loss, the right optic disc is pale and the arteries are attenuated. Visual acuity remains hand motions. Giant cell arteritis is a systemic, vascular, inflammatory disease. Visual loss is generally not reversible even with systemic steroids. Although immediate steroid therapy is recommended to protect vision in the remaining eye and to reduce the likelihood of arterial occlusion elsewhere, some patients will develop visual loss in the second eye despite steroid therapy. Adequate steroid dosage is determined by a consideration of the patient's symptoms, signs, and erythrocyte sedimentation rate. In addition to anterior ischemic optic neuropathy, giant cell arteritis may also cause central retinal artery occlusion, retinal hemorrhages and cotton wool spots, ocular motor abnormalities, and cortical blindness. Slide 19. Anterior ischemic optic neuropathy with giant cell arteritis. This 70-year-old female noted the sudden onset of blurred vision in her left eye. She had been treated in the past for arthritis and had recently complained of severe temporal headaches and left ear pain. The right eye was normal. Visual acuity left eye was 2400s, with defective color vision, an afferent pupillary defect, and a superior altitudinal field defect involving fixation. Upper left. The left optic disc is hyperemic, with hemorrhages superiorly and pallor inferiorly. The retinal arteries show generalized and focal constriction. The patient's sedimentation rate was 68. She was immediately started on high-dose systemic steroids, and a temporal artery biopsy was performed. Upper right. A high-power section from the temporal artery demonstrates fragmentation and destruction of elastic tissue. Arrows point to remaining fragments of the elastic lamina. Lower left. In another section of the temporal artery, arrows point to giant cells. Over the next 2 months, the sedimentation rate fell from 68 to 25, and the patient's headaches and ear pain disappeared. Lower right. 3 months later, the left optic disc is pale and atrophic, and the retinal arteries are uniformly narrowed. Visual acuity and fields did not change. Although the sedimentation rate is greater than 60 in most cases of giant cell arteritis, there are rare instances in which patients with giant cell arteritis have normal sedimentation rates. Thus, when clinical suspicion is high, one should consider steroid therapy unrelated to the sedimentation rate. Temporal artery biopsy should establish the diagnosis. We should insert one word of caution regarding temporal artery biopsy. There are patients with severe carotid occlusive disease in whom the superficial temporal artery on either side may serve as a major blood supply to the intracranial circulation. Biopsy of this artery could conceivably lead to severe cerebral ischemia. For this reason, in the absence of clinical symptoms or signs suggesting giant cell arteritis, we will not perform a temporal artery biopsy in a patient with anterior ischemic optic neuropathy. Slide 20. Anterior ischemic optic neuropathy and diabetes mellitus. This 26-year-old female with brittle diabetes mellitus had noted blurred vision in her left eye for 2 weeks. Visual acuity was 20/20 right eye and 20/30 left eye. Color vision was diminished in the left eye, and there was a left afferent pupillary defect. Upper left. The left optic disc is hyperemic and shows surface neovascularization. The retinal vessels are dilated, and there is a subhyaloid hemorrhage above the macula. Upper right. The left macula shows numerous small hemorrhages, microaneurysms, and intraretinal microvascular abnormalities typical of diabetes mellitus. The arrows point to surface neovascularization. Lower left. The visual field, left eye, demonstrates an altitudinal defect. In this case, sudden loss of vision, disc hyperemia out of proportion to neovascularization, an afferent pupillary defect, and an altitudinal field defect all suggest a diagnosis of anterior ischemic optic neuropathy. Anterior optic nerve involvement may be seen in diabetic patients with or without retinopathy. Toxic metabolic changes, diffuse peripheral neuritis, and poor diabetic control have all been proposed as possible etiologic factors. However, since diabetes causes diffuse microangiopathy, it is probable that optic nerve involvement is due to occlusion of small posterior ciliary vessels supplying the prelaminar portion of the optic nerve. Lower right. The artist's sketch demonstrates segmental occlusion of perforating neural branches of the posterior ciliary arteries, resulting in anterior ischemic optic neuropathy. Slide 21. Optic disc edema and retinopathy in systemic lupus erythematosus. This 32-year-old female noted sudden visual field loss in her right eye. Her only other complaint was mild aching of both lower legs. Visual acuity was 20/15 OU. The right eye had defective color vision, an afferent pupillary defect, and a superior nasal visual field defect. The left eye was normal. Upper left. The superior and nasal portions of the right optic disc are edematous and hyperemic. The retinal veins are dilated, and 3 large cotton wool spots are present. Lower left. A fluorescein angiogram shows leakage from dilated optic disc capillaries. Medical evaluation included 3 positive LE preps, a normal sedimentation rate, a negative screen for antinuclear antibodies, and normal serum complement levels. The patient was started on prednisone. Upper center. After 2 weeks of steroids, the optic disc is less hyperemic and edematous. The cotton wool spots are resolving. The inferior temporal retinal arteries show focal narrowing. Lower center. A fluorescein angiogram after 2 weeks of steroids shows that the optic disc capillaries no longer leak fluorescein. Upper right. After 6 weeks of steroids, the right optic disc is no longer edematous, but there is temporal pallor. The cotton wool spots have almost disappeared. Lower right. A nasal visual field defect corresponds to the temporal disc pallor. This patient is presumed to have systemic lupus erythematosus, or SLE. Patients with SLE have been described with anterior ischemic optic neuropathy and with papilledema and pseudotumor cerebri. In addition, SLE may produce a diffuse retinal vasculitis. Young patients, particularly females, who present with anterior ischemic optic neuropathy should have a complete connective tissue evaluation, including LE preps, erythrocyte sedimentation rate, ANA determination, and serum complement levels. As with any patient on steroids, the physician should be aware of the potential hazards of steroid treatment. Slide 22. Papillophlebitis. This 25-year-old female had noted a subtle change in the vision of her right eye for 1 week. Visual acuity was 20/20 OU with normal color vision, normal pupils, and full visual fields. The left fundus was normal. Upper left. The right optic disc is edematous and partially obscured by superficial hemorrhages and cotton wool spots. The retinal veins are markedly dilated. Upper right. The macula has several small parafoveal hemorrhages and moderate vascular tortuosity. A systemic evaluation was normal, and no treatment was recommended. The patient's visual symptoms disappeared over the next 6 weeks. Lower left and lower right. 2 months later, the right optic disc, macula, and retinal vessels are normal. This patient represents a variant of central retinal vein occlusion known as papillophlebitis. The etiology may be a mild inflammation involving the central retinal vein or its tributaries, or both. Patients with papillophlebitis are invariably young and healthy and have no evidence of systemic disease such as hypertension or diabetes mellitus. Although steroids have been used to treat papillophlebitis, their efficacy has not been proven. The etiology of this condition remains unclear, but visual and ophthalmoscopic recovery is the rule. A variant of this condition, called optic disc vasculitis type 1 by Hayray and the big blind spot syndrome by Miller, consists of unilateral optic disc edema without signs of optic nerve dysfunction. The patients are young and healthy and have normal cerebrospinal fluid examinations. Slide 23, papillophlebitis. This 33-year-old male noticed blurred vision in his left eye that cleared within several hours. During the next few weeks, he experienced intermittent blurred vision always in the left eye. Visual acuity was 20/20 right eye and 20/25 left eye. The left visual field showed enlargement of the blind spot. The right eye was normal. Upper left. The left optic disc is edematous and surrounded by superficial, flame-shaped hemorrhages. The retinal veins are dilated and tortuous. Upper right. A fluorescein angiogram shows diffuse dye leakage from optic disc vessels and retinal veins. A medical evaluation that included a complete blood count, erythrocyte sedimentation rate, serum protein electrophoresis, and a 5-hour glucose tolerance test was normal, and no treatment was recommended. The patient noted no further change in his vision. 1.5 years later, visual acuity left eye was 20/25 with mildly defective color vision. The left pupil was slightly less reactive to light than the right pupil, and the left visual field was normal. Lower left. 1.5 years after initial evaluation, the left optic disc is slightly pale. An abnormal corkscrew vessel is seen at the disc margin at 7 o'clock. Shunt vessels are present adjacent to the inferior temporal vein. The macula is no longer edematous, but has numerous pigment epithelial abnormalities. Lower right. During the arterial phase of the fluorescein angiogram, there is no filling of shunt vessels, indicating that they are venous to venous shunts. There was late filling of these vessels, but no leakage. There are 2 possible explanations for the favorable prognosis in papillophlebitis. First, younger patients with healthy vessels may be able to tolerate brief periods of central retinal vein obstruction. Second, the etiology of the central retinal vein obstruction may be different in younger patients. The typical features of papillophlebitis are an ophthalmoscopic picture of a central retinal vein occlusion with normal or near normal visual acuity in a young, healthy patient. Although this patient presently has no ocular symptoms, the abnormal fundus findings suggest that he may have had a true central retinal vein occlusion. Slide 24. Optic disc edema and pars planitis. This 15-year-old female complained of decreased vision in both eyes and occasional mild headache. Visual acuity was 20/30 OU and both optic discs were edematous. Because she had good vision and bilateral optic disc edema, her initial ophthalmologist thought she had papilledema, and she was referred to a neurosurgeon for further evaluation. Despite a normal neurological evaluation, neuroradiologic studies were performed. A cerebral angiogram and pneumoencephalogram were both normal. Cerebrospinal fluid taken at the time of pneumoencephalography was under mildly elevated pressure, but cerebrospinal fluid protein and glucose were normal. A diagnosis of pseudotumor cerebri was made. Steroid therapy was begun with dramatic resolution of optic disc edema. When steroids were tapered, the disc edema reappeared. The patient subsequently had placement of a thecoperitoneal shunt in an effort to prevent permanent optic nerve damage from presumed chronic increased intracranial pressure. However, despite a functioning shunt, she continued to have bilateral decreased vision and optic disc edema. When examined at the Wilmer Institute, the patient had visual acuity of 20/40 OU and bilateral anterior chamber and vitreous inflammation. Upper left and upper right. Both optic discs are hyperemic and edematous. Lower left. The left macula shows cystoid changes that were more apparent on slit lamp biomicroscopy. Lower right. A fluorescein angiogram demonstrates leakage from the optic disc and parafoveal capillaries, resulting in a cystoid pattern in the left macula. Areas of white vitreous condensation adjacent to the inferior ora serrata were present in both eyes. This patient has pars planitis, characterized by intraocular inflammation, cystoid maculopathy, and optic disc edema. When the correct diagnosis was made, her shunt was removed. Although there is no evidence that steroid therapy is effective in pars planitis, this patient's inflammation and optic disc edema improved when steroids were used. This patient was felt to have pseudotumor cerebri. However, her reduced visual acuity and lack of severe headaches should have suggested another diagnosis, and a careful initial slit lamp evaluation could have established the correct diagnosis and prevented a neurosurgical intervention. Slide 25. Optic disc edema and APM-PPE. This 27-year-old male developed a high fever, swollen glands, and a stiff neck. At the same time, he noted blurred vision and photophobia in both eyes. Visual acuity was 20/30 bilaterally. Upper left and lower left. The optic discs are normal, but pigment epithelial changes are visible in the peripapillary regions of both eyes. A diagnosis of acute posterior multifocal placoid pigment epitheliopathy was made. The patient's visual acuity gradually improved on systemic steroids. 3 years later, he again noted reduced vision in his right eye. Visual acuity was 20/30 right eye and 20/20 left eye. Upper center and lower center. Both optic discs are now hyperemic and edematous, but no hemorrhages or exudates are seen. Peripapillary retinal pigment epithelial changes are prominent in both eyes. Upper right and lower right. A fluorescein angiogram demonstrates leakage from both optic discs and accentuates the peripapillary pigment epithelial changes. The alternating areas of hyper and hypofluorescence may reflect swelling of superficial choroid and retinal pigment epithelium that probably occurs in this disorder. The patient was treated with steroids with resolution of optic disc edema and improvement in visual acuity. Acute posterior multifocal placoid pigment epitheliopathy is usually a benign self-limited inflammatory disorder that involves the retinal pigment epithelium or choriocapillaris or both. Patients with this disorder may have an associated viral illness that can involve the central nervous system, and adenovirus 5 has been isolated from spinal fluid in such patients during the acute phase of the disease. The efficacy of steroid treatment for APM-PPE has not been established, but some investigators believe that a trial of steroids is indicated if visual acuity does not return in several weeks. Slide 26. Bilateral anterior optic neuritis and viral infection. This 18-year-old female developed a flu-like illness characterized by malaise, fatigue, and low-grade fever. 1 week later, she noted blurred vision in both eyes. Visual acuity was 10/200 right eye and 20/70 left eye. Color vision was severely impaired bilaterally, and visual fields showed central scotomas. A right afferent pupillary defect was present. Upper left and upper right. Both optic discs are edematous with generalized blurring of the peripapillary retinal nerve fiber layer. 1 week later, visual acuity had decreased to hand motions right eye and 20/400 left eye. The patient was started on systemic steroids, and within 1 week, visual acuity had returned to 20/20 with normal color vision and full visual fields in both eyes. Lower left and lower right. 2 months after the onset of her illness, the patient has normal optic discs. Inflammation of the laminar and prelaminar portions of the optic nerve may result in optic disc edema. Visual loss is often sudden and is associated with defective color vision and an afferent pupillary defect, as in anterior ischemic optic neuropathy. However, while the typical visual field defect in ischemic optic neuropathy is altitudinal or arcuate, the classical visual field defect in anterior optic neuritis is a central scotoma. Bilateral optic neuritis may occur with a variety of systemic viral infections. Whether viral particles are present in the optic nerve is unknown. Although this patient's visual acuity improved rapidly after institution of steroid therapy, there is no statistical evidence that steroids alter the eventual outcome in patients with either anterior or retrobulbar optic neuritis. Slide 27. Optic disc edema and meningitis. This 15-year-old male developed headache, fever, and stiff neck. Visual acuity was 20/15 OU with normal color vision, although there was a subjective decrease in sensitivity to color on the right. Pupils were normal, and visual fields were full. Upper left. The right optic disc is hyperemic and edematous with an indistinct margin. Lower left. The left optic disc is mildly hyperemic with a slightly blurred margin. Upper center and lower center. Fluorescein angiography of the right optic disc demonstrates dilatation of superficial disc capillaries with late leakage from these vessels. A neurologic evaluation revealed no focal findings. A lumbar puncture demonstrated a normal opening pressure with an elevated protein and numerous mononuclear cells. Cerebrospinal fluid cultures were negative, and a diagnosis of viral meningitis was made. The patient was given supportive therapy, and within 2 weeks, his headaches and stiff neck had resolved. He continued to deny visual problems. Upper right and lower right. 3 months later, the optic discs are normal. Optic disc edema in patients with meningitis is generally due to a perineuritis that begins as an inflammation of the pia and arachnoid and spreads along these sheaths to involve the optic nerve. Although there is often marked reduction in visual acuity, many patients have optic disc edema with normal visual acuity, resulting in a mistaken diagnosis of papilledema until a lumbar puncture reveals normal intracranial pressure. Even when visual acuity is reduced, resolution of the inflammation is usually associated with return of acuity to normal. Slide 28. Optic neuritis and syphilis. This 35-year-old male noticed mild visual loss in his left eye. Visual acuity was 20/20 right eye and 20/25 left eye. Color vision was slightly diminished on the left, but there was no afferent pupillary defect. The left visual field showed a small central scotoma to a red test object. Slit lamp examination revealed mild iritis, cheratic precipitates, and clear vitreous in both eyes. General physical examination showed a maculopapular eruption on both palms, and serologic test for syphilis was positive in both serum and spinal fluid. Left. The left optic disc is edematous and hyperemic, with dilatation of superficial disc vessels as well as retinal veins. Arrows point to perivascular exudates along small superior and inferior temporal vessels. The patient was treated with penicillin for 4 weeks. The rash disappeared and the anterior chamber reaction resolved. Visual acuity in the left eye improved to 20/20 and the central scotoma resolved. Right. 7 weeks later, the left optic disc is mildly hyperemic and the perivascular exudates have resolved. An unusual aspect of this case is the unilateral involvement, since syphilitic optic neuritis is usually bilateral. With appropriate antibiotic treatment, the visual prognosis is excellent. Slide 29. Anterior optic neuritis in multiple sclerosis, pseudo-Foster-Kennedy syndrome. This 39-year-old female experienced sudden loss of vision in the left eye 8 years previously. At that time, the right eye had 20/15 acuity and was otherwise normal. The left eye had counting fingers acuity and moderate optic disc edema. Despite steroid therapy, left eye vision rapidly fell to no light perception. During the next 8 years, the patient had 2 episodes of transient mild hemiparesis with full recovery. Skull X-rays, brain scan, and lumbar puncture were normal. 3 days prior to evaluation at the Wilmer Institute, the patient experienced severe pain behind her right eye that was worse on eye movement. 48 hours later, there was sudden loss of vision in the right eye. Visual acuity was counting fingers right eye with a large central scotoma. The left eye had no light perception. Upper left. The right optic disc shows mild edema and hyperemia with blurring of the disc margin. There are no hemorrhages or exudates. Upper right. The left optic disc is pale with loss of the nerve fiber layer. Skull X-rays and an ME scan were normal. Lumbar puncture revealed clear cerebrospinal fluid with normal opening pressure, normal protein, and a mild pleocytosis. Myelin basic protein immunoassay was positive, indicating a demyelinating process. Steroid therapy was initiated, and visual acuity improved slowly. Lower left. After 2 weeks of steroid therapy, the right optic disc is no longer edematous. Visual acuity is 2200. Lower right. 2 months later, visual acuity has improved to 2040. Color vision remains defective, and there is a small central scotoma. The optic disc has definite temporal pallor. This patient has anterior optic neuritis, probably associated with multiple sclerosis. She also represents a pseudo-Foster-Kennedy syndrome, in that she presented with optic disc edema in one eye and optic atrophy in the other. The history of sudden visual loss in the initially affected eye, coupled with a history of sudden visual loss, defective color vision, and a central scotoma in the left eye with optic disc edema, effectively rules out the possibility of an intracranial mass as the cause of this patient's complaints. The myelin basic protein test, recently developed by Cohen and co-workers, is a radioimmunoassay for a breakdown product of myelin that accumulates in the cerebrospinal fluid during demyelinating processes. The test appears to correlate with the degree of activity of multiple sclerosis. This patient had an elevated myelin basic protein on the basis of unilateral optic neuritis, despite the absence of subjective neurologic complaints or objective neurologic signs. This technique may prove to be of value in distinguishing optic neuritis from anterior ischemic optic neuropathy, since both may present with sudden loss of acuity, visual field defects, and optic disc edema. The patient with optic neuritis is more likely to have a central scotoma, as in this case, whereas the patient with anterior ischemic optic neuropathy is more likely to have an altitudinal or arcuate visual field defect. Slide 30. Optic neuritis with macular star. This 24-year-old female experienced 3 days of severe pain on movement of the right eye, followed by loss of vision in that eye 1 week after a presumed viral illness characterized by malaise and fever. The right eye had visual acuity of 2400ths, loss of color vision, a large central scotoma, and an afferent pupillary defect. The left eye was normal. Upper left. The right macula contains lipid deposits in a star pattern especially prominent on the nasal side. Upper center. The right optic disc is edematous and the retinal veins are dilated. Upper right. A fluorescein angiogram shows diffuse leakage from disc capillaries. Lower left. 10 seconds later, note continued leakage from the optic disc. There are no retinal vascular abnormalities. Lower center. 2 weeks later, the right optic disc has minimal edema and normal color. The star figure in the nasal macula has partially resolved. Lower right. 8 months later, visual acuity in the right eye is 20/20. The optic disc and macula are both normal. This patient represents a syndrome of anterior optic neuritis with macular star formation. this syndrome has been called Leber's stellate maculopathy because the macular star figure is especially prominent, and the associated optic disc edema often resolves before the patient sees an ophthalmologist. However, in these patients, fluorescein angiography demonstrates no retinal vascular abnormalities in the macula, indicating that the macular star is caused by a leakage from disc vessels and that the process is a primary optic neuritis and not a primary macular disorder. Except for a history of viral illness preceding visual loss, as in this patient, we are not aware of any other associations. Slide 31. Optic disc edema and optic nerve meningioma. This 43-year-old female noted gradual loss of vision in her right eye. Visual acuity in the right eye was 20/30, with markedly diminished color vision and an afferent pupillary defect. The left eye was normal. Upper left. The right optic disc is edematous and elevated. No hemorrhages are seen. Upper right. The visual field, right eye, shows a marked inferior temporal depression to large isopters and total loss of the temporal field to small isopters. This patient was followed for 1 month. Visual acuity in the right eye progressed from 20/20 to 20/200, and the visual field loss increased. Skull X-rays were normal, but ME scan demonstrated slight enlargement of the orbital portion of the right optic nerve. Exploration of the right orbit disclosed an optic nerve sheath meningioma extending to the orbital apex and into the right optic canal. Lower left. Arrows point to the right optic nerve, which is surrounded and compressed by a mass of tissue contained within the dural nerve sheath. Lower right. A histologic section through this area demonstrates compression of the optic nerve by a nerve sheath meningioma. In contrast to patients with sudden visual loss and optic disc edema who have vascular or inflammatory lesions, patients with slowly progressive visual loss associated with optic disc edema generally have orbital compressive lesions. Patients presenting in this fashion should be evaluated for other signs of an orbital process, such as limitation of ocular motility, proptosis, and chemosis. Orbital and optic canal polytomography, as well as computerized tomography, may be of value. Although nerve sheath meningiomas cannot be removed without sacrificing vision in the involved eye, failure to excise them may in time lead to extension of the meningioma through the optic canal and into the middle cranial fossa. Slide 32. Optic disc edema and optic nerve glioma. This 22-year-old male had noted slowly progressive visual loss in the left eye for 1 year. The left eye had 24/100 visual acuity, reduced color vision, a subtle afferent pupillary defect, and 2 millimeters of proptosis. Visual field showed mild constriction. Extraocular movements were full. The right eye was normal. Upper left. The left optic disc is edematous and hyperemic. Upper center. A red-free photograph shows disc edema and retinal stria extending through the macula. Upper right. A fluorescein angiogram shows leakage from superficial disc capillaries. Lower left. Skull X-rays were normal, but ME scan shows a fusiform swelling of the left optic nerve. The left orbit was explored. Beginning just behind the globe, the optic nerve was enlarged to approximately 4 times normal size before it slowly tapered back to normal as it approached the orbital apex. The nerve was divided posterior to the globe and at the orbital apex, and was removed, leaving the globe intact. Lower center. In a cross-section of the operative specimen, the shorter arrows outline the perimeter of the markedly enlarged optic nerve. The long arrows point to the thickened arachnoid sheath. Lower right. High-power section through the tumor shows increased cellularity and generalized thickening of the nerve fiber bundles. This patient represents a typical example of optic nerve glioma, a benign hamartoma that enlarges by accumulation of mucopolysaccharide substance between glial astrocytes. Visual acuity in patients with optic nerve gliomas may be reduced or normal. Some physicians feel these tumors should be completely excised to prevent extension into the chiasm and involvement of the other eye. Hoyt and others have recommended that patients with optic gliomas be followed at regular intervals without attempted surgical removal. We agree with Hoyt that optic nerve gliomas are generally benign, and that, once the possibility of meningioma has been ruled out, patients can be followed without fear of involvement of the opposite eye. Slide 33, optic disc edema and orbital hemangioma. This 56-year-old female had noted poor vision in the left eye for 1 year. The right eye was normal, but the left eye had 20/30 visual acuity, enlargement of the blind spot, and 3 millimeters of proptosis. Upper left. The left optic disc is edematous and hyperemic. Upper right. Choroidal folds extend horizontally from the disc through the macula. Lower left. A fluorescein angiogram shows alternating areas of hypo and hyperfluorescence caused by choroidal folds. The patient's reasonably good acuity, almost normal field, and long history suggested a diagnosis of orbital pseudotumor, and a therapeutic trial of steroids was given. Because proptosis increased despite the course of systemic steroids, the left orbit was explored, and a small, encapsulated reddish mass was removed from within the muscle cone. Lower right. A histologic section through the orbital mass shows that it is a cavernous hemangioma comprised of multiple blood vessels separated by a fibrous syncytium. Encapsulated masses, such as hemangiomas and dermoids, can compress the orbital optic nerve, causing optic disc edema and decreased vision. Although these masses are generally apparent on computerized tomography, this patient was seen prior to its development. In recent years, computerized tomography, ultrasonography, and polytomography have facilitated rapid diagnosis and management of orbital lesions. Slide 34, dysthyroid optic neuropathy. This 52-year-old female with hypothyroidism stopped taking her thyroid replacement 1 month previously. 2 weeks previously, she noted decreased vision in her right eye. The right eye had 20/100ths visual acuity, defective color vision, a central scotoma, and an afferent pupillary defect. Left eye visual acuity was normal. Both eyes were slightly proptotic. Thyroid studies showed markedly reduced thyroid function. Skull X-rays were normal. Upper left. The right optic disc is hyperemic with a blurred margin. Upper center, a fluorescein angiogram shows subtle leakage from optic disc vessels. Upper right. An ME scan shows enlarged extraocular muscles and a small mass at the orbital apex. The patient was given thyroid replacement, and within 3 days noted visual improvement in the right eye. Lower left. 4 days after thyroid replacement was started, the right optic disc is no longer hyperemic and the edema has subsided. Visual acuity is 20/25. Lower center. On repeat ME scan, the previously observed apical mass is no longer present. Lower right. A histologic section of an extraocular muscle from another patient with thyroid ophthalmopathy shows infiltration of the muscle fibers by plasma cells and lymphocytes. The spaces between individual muscle fibers contain large amounts of mucopolysaccharide. This patient had a compressive optic neuropathy associated with a dysthyroid state. Computerized tomography in such patients often demonstrates prominent ocular muscles, bulging of the medial canthus, and an apical mass. When orbital exploration is performed, the ocular muscles are found to be enlarged due to infiltration by mononuclear cells and mucopolysaccharide. The apical mass in thyroid disease is probably the result of generalized swelling and enlargement of the rectus muscles at their common site of origin from the annulus of Zinn. This swelling compresses the optic nerve at the orbital apex, causing secondary optic disc edema and decreased vision. Slide 35, leukemic optic neuropathy. This 10-year-old male with acute lymphocytic leukemia complained of decreased vision in his right eye. Visual acuity was 24/100ths right eye and 20/20 left eye. Upper left. The right optic disc is elevated and grayish-white with obscuration of the retinal vessels. A small superficial hemorrhage is present at the temporal disc margin. Upper right. Peripheral blood smear shows numerous large immature lymphocytes. Lower left. A histologic section from a similar case shows diffuse infiltration of the optic nerve by leukemic cells, resulting in marked elevation of the optic nerve head. Lower right. A high-power section of the retrolaminar optic nerve shows extensive leukemic infiltration. The optic nerve may be infiltrated by reticulum cell sarcoma, lymphoma, Hodgkin's sarcoma, and metastatic carcinoma, in addition to leukemia. Although infiltration of the nerve head does not necessarily indicate increased intracranial pressure, the ophthalmoscopic picture is often mistaken for true optic disc edema. Slide 36. Sarcoid optic neuropathy. This 23-year-old female developed hilar adenopathy. A skin test for tuberculosis was negative, and a cervical lymph node biopsy was consistent with sarcoidosis. 6 months later, she developed pain, redness, photophobia, and visual loss in the left eye. Visual acuity was 20/20 right eye and 20/200 left eye. The right eye was normal, and the left eye showed cell and flare in the anterior chamber with large mutton fat, keratic precipitates, and vitreous cells. Upper left. A fluffy white lesion is seen above the left optic disc. Retinal vessels are dilated over this lesion, and vitreous opacity partially obscures the disc. With a history of biopsy-proven sarcoidosis from a cervical lymph node 6 months earlier, the presumed diagnosis was a peripapillary choroidal granuloma secondary to sarcoidosis. The patient was treated with systemic steroids, and visual acuity improved to 20/100ths within 2 weeks and continued to improve subsequently. Upper right. A histologic section through the eye of a similar case shows a large granulomatous lesion overlying the optic disc. Lower left. A high-power section of this lesion demonstrates multiple granulomas consistent with sarcoidosis. Lower right. A photograph from another patient with sarcoidosis demonstrates marked infiltration of the left optic disc. Inflammatory conditions such as sarcoidosis can produce granulomatous infiltration of the optic disc. In such cases, systemic steroids may be beneficial. Slide 37. Toxic anterior optic neuropathy. This 12-year-old girl with hemoglobin SC disease was on long-term chloramphenicol therapy for Salmonella osteomyelitis when she noted decreased vision in both eyes and numbness and pain in both feet. Visual acuity was 20/100ths right eye and 20/80 left eye. A central scotoma was present in the right eye, and there was a paracentral scotoma in the left eye. Touch and vibration sense were diminished in both legs, and deep tendon reflexes could not be elicited. Upper left. The left optic disc is mildly hyperemic and edematous with blurring of the margin. Upper center. The fluorescein angiogram shows prominent superficial disc capillaries. Upper right. 10 minutes after injection, dye leakage from the optic disc is evident. The right optic disc had a similar appearance. Chloramphenicol was discontinued immediately, and the patient was treated empirically with large doses of parenteral vitamin B12 and oral B-complex vitamins. Visual acuity rapidly improved in both eyes. Lower left. 2 months after stopping chloramphenicol, the left optic disc is no longer edematous, the hyperemia has resolved, and there is moderate temporal pallor. Lower center and lower right. A fluorescein angiogram taken 2 months after stopping chloramphenicol shows normal optic disc capillaries and no dye leakage. Chloramphenicol is one of a number of agents that can cause a toxic anterior optic neuropathy. In most cases, patients have bilateral reduction in visual acuity and color vision, full peripheral fields, and bilateral central or secocentral scotomas. Most toxic optic neuropathies resolve once the offending agent is discontinued. Slide 38. optic disc edema and hypotony. This 60-year-old male had an uncomplicated intracapsular cataract extraction in his right eye. Postoperatively, he developed a shallow anterior chamber with an intraocular pressure of 2 due to a cyclodialysis cleft. Upper left. The right optic disc is elevated and slightly hyperemic. It is seen through hazy media due to severe hypotony. Upper right. A fluorescein angiogram shows dilated optic disc capillaries. Lower left, a late-phase fluorescein angiogram shows extensive leakage from the right disc. The cyclodialysis cleft was closed by penetrating diathermy. The intraocular pressure returned to normal, and the optic disc edema cleared. Optic disc edema from hypotony may occur after intraocular surgery or trauma. The diagnosis is generally obvious from the history and the finding of low intraocular pressure. Although the mechanism of disc edema from hypotony is in question, Minkler and co-workers have shown a blockage of optic nerve axoplasmic transport at the lamina cribrosa in experimental hypotony, similar to that observed in experimentally increased intracranial pressure. However, whether blockage of axoplasmic transport is the primary cause of optic disc edema or is a secondary associated finding in all types of disc edema is unknown. Lower right, blockage of axoplasmic transport at the lamina cribrosa in experimental hypotony produces a picture identical to this phase contrast photomicrograph of the optic disc in experimentally increased intracranial pressure. We now leave the subject of optic disc edema and begin our discussion of elevated disc anomalies that simulate optic disc edema. Slide 39, optic disc drusen. This 25-year-old male was noted to have optic disc abnormalities during a routine eye examination. He had no visual complaints. Visual acuity was 20/20 OU, and visual fields were full. Upper left. The right optic disc contains large, yellow, glistening drusen at its nasal border. The retinal vessels are normal. Upper right. The left optic disc also has glistening drusen that are particularly prominent at its nasal aspect. Lower left. Fluorescence of the drusen is seen prior to injection of fluorescein dye, a phenomenon known as autofluorescence. Lower right. 30 minutes after injection, dye molecules adherent to the drusen result in late hyperfluorescence. This patient has bilateral optic disc drusen without visual symptoms or signs. Drusen may occur in up to 1% of the population and are often familial. Since the drusen are often buried beneath the disc surface, they are more frequent in pathologic than in clinical series. Many patients with drusen have abnormal branching vascular patterns on the optic disc surface, relatively large blood vessels connecting superficial and deep disc circulations, and increased disc capillarity. The tendency to develop optic disc drusen may result in part from a congenitally abnormal disc vasculature that allows transudation of plasma proteins that serve as a nidus for the deposition of extracellular material. Drusen are insoluble in water and ether and stain positively for amino acids, acid mucopolysaccharides, calcium, and hemosiderin. They are not birefringent, and they stain negatively for both amyloid and fibrin. Slide 40, optic disc drusen. This 10-year-old male complained of intermittent headaches unassociated with nausea or vomiting. He had no neurologic findings. Visual acuity was 20/20 right eye and 20/15 left eye, with normal color vision and slightly enlarged blind spots. Upper left. The left optic disc is elevated, but normal nerve fiber layer striations are visible. The retinal vessels are tortuous but are not obscured as they cross the disc surface. A small mass is barely visible at the superior disc margin. The right optic disc has a similar appearance. Upper right. In this red-free photograph, normal nerve fiber layer striations are seen despite elevation of the disc, and an arrow points to a small mass at the superior disc margin. Lower left. 15 seconds after fluorescein injection, disc capillaries have an abnormal branching pattern but do not leak. Lower right. 30 minutes after injection, late hyperfluorescence in a scalloped pattern typical of drusen is present. This young boy complained of headaches and had bilateral optic disc elevation. He had no neurologic signs, no visual field defect, and no visual acuity loss. In addition, the peripapillary retinal nerve fiber layer was not blurred, the retinal vessels were not obscured as they emerged from the center of the disc, and the fluorescein angiogram showed no leakage from disc capillaries. The lack of clinical evidence of optic disc edema should suggest the diagnosis of optic disc drusen and prevent the clinician from proceeding with any further evaluation. Slide 41. Optic disc drusen mistaken for papilledema. On routine eye examination, this 26-year-old male was found to have 20/15 visual acuity and slightly enlarged blind spots in both eyes. Upper left and upper right. Both discs are elevated. However, the retinal vessels are clearly seen as they cross the optic disc surface. This patient's ophthalmologist thought he had papilledema and referred him for neurological evaluation. Despite a normal neurologic examination, the patient underwent skull X-rays, EEG, brain scan, cerebral arteriogram, and ventriculogram, all of which were normal. A diagnosis of pseudotumor cerebri was made despite the absence of elevated intracranial pressure, and the patient was started on systemic steroids. When his ophthalmoscopic picture failed to change after a course of steroids, the patient was referred to the Wilmer Institute. When his ophthalmoscopic picture failed to change after a course of steroids, the patient was referred to the Wilmer Institute. Lower left and lower right. Red-free photographs clearly show that the retinal vessels cross the surface of the disc without being obscured by disc tissue. No hemorrhages or exudates are present. If elevation of the optic disc were in fact caused by true edema, one would expect the retinal vessels to be obscured by overlying edematous nerve tissue. Instead, the vessels are clearly visible as they cross the disc surface, suggesting that the discs are elevated by some other mechanism, probably buried drusen. Even if one cannot see definite drusen, this ophthalmoscopic picture should not be confused with optic disc edema. Slide 42. Composite of optic disc drusen. Upper left and upper right and lower left. These three photographs from different patients illustrate the major findings in buried drusen of the optic disc. Although all of the discs are elevated, there are at least 4 ophthalmoscopic features that point towards a diagnosis of buried drusen rather than optic disc edema. First, the retinal vessels are clearly seen as they traverse the disc surface. True edema of the optic disc is primarily intra-axonal, and the swollen nerve fibers obscure the retinal vessels as they cross the disc surface. Second, the optic cup is either absent or abnormal. In most cases of optic disc edema, the major disc swelling occurs at the periphery of the disc, so that the central cup is generally preserved even in advanced cases. Third, although the retinal vessels may be tortuous and have an anomalous branching pattern in eyes with optic disc drusen, the vessels are not dilated and do not leak fluorescein as in optic disc edema. Fourth, normal retinal nerve fiber layer striations are preserved up to the disc margin in eyes with optic disc drusen, but are lost due to axonal swelling in eyes with optic disc edema. Lower right. The artist's sketch shows that the location of buried drusen with respect to the optic disc surface may vary considerably. Drusen that are located just beneath the disc surface may be easily seen with the ophthalmoscope, while drusen located deep to the disc surface may be invisible, producing elevation of the optic disc without edema. Slide 43. Optic disc drusen and subretinal hemorrhage. Upper left, upper right, and lower left. This slide illustrates the typical subretinal hemorrhages that may be associated with buried drusen of the optic disc. The 3 color photographs show that the optic discs are elevated without edema. Surrounding a portion of each disc is a small, flat hemorrhage deep to the retina. In some cases, the hemorrhage may extend beneath the retinal pigment epithelium as well. These hemorrhages may be asymptomatic or may extend into the macula, causing decreased visual acuity. In most cases, Spontaneous resolution occurs unless subretinal neovascularization is present. It has been postulated that hemorrhages develop when the drusen compress and damage the walls of deep optic disc vessels. This phenomenon is illustrated schematically lower right. Slide 44. Optic disc drusen and subretinal neovascularization. This 12-year-old female gave a 3-month history of poor vision in her left eye. Visual acuity was 20/20 right eye and 2100 left eye, with an enlarged blind spot in the right eye and a secocentral scotoma in the left eye. Upper left. The right optic disc is elevated with a blurred margin, and there is no central cup. The retinal vessels are not obscured as they cross the disc surface, and there are no hemorrhages. Normal peripapillary retinal nerve fiber layer striations are present. Upper right. The left optic disc is also elevated, has no central cup, and has an irregular border. The retinal vessels cross the disc surface in full view. A small tortuous vessel is seen on the disc at 11 o'clock. A pigmented lesion is present in the papillomacular bundle, and the retinal pigment epithelium in the macula is atrophic. Lower left. A fluorescein angiogram shows that the pigmented lesion in the papillomacular bundle represents a subretinal neovascular membrane. The hyperfluorescence in the center of the macula represents increased transmission of choroidal fluorescence through an area of retinal pigment epithelial atrophy. The pigment epithelium has lost its pigment due to long-standing detachment of sensory retina. Lower right. 30 minutes following dye injection, the hyperfluorescence in the center of the macula has faded almost entirely, indicating that this was a transmission defect or an RPE window defect. The area of subretinal neovascularization, however, appears brighter, indicating continued leakage of fluorescein dye. Although this patient's fundi exhibited several ophthalmoscopic features characteristic of buried optic disc drusen, several ophthalmologists thought the patient had papilledema, and she underwent skull x-rays, computerized tomography, and pneumoencephalography, all of which were normal. The association of subretinal neovascularization with optic disc drusen is well described, but the reason for its development is unclear. It is possible that drusen create abnormal cleavage planes within the optic disc, and that capillaries emerge from these planes to lie in the subpigment epithelial or subsensory retinal spaces. Eventually, these vessels may cause a serous or serosanguinous macular detachment that results in visual loss. Slide 45. Optic disc drusen and visual acuity loss. This 52-year-old female complained of blurred vision in both eyes. Visual acuity was 20/30 OU with slightly decreased color vision. Pupils were normal. Upper left. The left optic disc shows numerous drusen just beneath the nerve fiber layer. The disc is pale yellow and the retinal vessels are normal. Upper right. A magnified red-free photograph of the left optic disc shows loss of the peripapillary retinal nerve fiber layer. Lower left. The left visual field shows arcuate defects and irregular constriction to all isopters. Lower right. A histologic section from another patient shows how buried drusen may compress the optic nerve tissue anterior to the lamina cribrosa, causing atrophy of nerve fibers. Although buried drusen may initially cause elevation of the optic disc with preservation of normal peripapillary retinal nerve fiber layer striations, drusen can also compress surrounding nerve tissue, resulting in axonal destruction, loss of visibility of the peripapillary retinal nerve fiber layer, and progressive loss of visual acuity. Slide 46. Optic disc drusen and progressive visual field loss. This 31-year-old male noticed progressive difficulty seeing with his right eye. Upper left and lower left. Both optic discs contain multiple glistening yellow drusen. The retinal vessels have an abnormal branching pattern on the disc surface, and no peripapillary retinal nerve fiber layer is visible. Upper center. Fluorescence of drusen in the right optic disc prior to dye injection illustrates the phenomenon of autofluorescence. Lower center. 30 minutes after injection of fluorescein, dye molecules have attached to the drusen, causing late hyperfluorescence. Upper right. Initial visual field in the right eye demonstrates an arcuate defect. Visual acuity at this time was 2025 right eye and 2015 left eye. 4 years later, visual acuity in the right eye is 2040, and the visual field has worsened lower right. Drusen may compress nerve fibers in the prelaminar portion of the optic nerve, causing atrophy of the peripapillary retinal nerve fiber layer and a progressive loss of visual field and acuity. Slide 47. Optic disc drusen and intracanalicular meningioma. This 18-year-old male complained of slowly progressive visual loss in his left eye. The right eye was normal. The left eye had 2100 visual acuity, defective color vision, and an afferent pupillary defect. Slit lamp biomicroscopy showed definite optic disc drusen. Upper left. A magnified view of the left optic disc demonstrates mild pallor and optic disc drusen. Upper right. The visual field, left eye, shows an irregular peripheral depression with a pericentral scotoma that involves fixation. The patient was observed for 1 month. Visual acuity in the left eye decreased from 2100 to 2300. Skull X-rays, optic canal polytomography, and computerized tomography were all normal. The patient refused further studies. 1 month later, visual acuity in the left eye had decreased to hand motions. Lower left. The visual field in the left eye 2 months after initial evaluation demonstrates only a small nasal island of vision. A repeat ME scan was normal, and cerebral angiography and pneumoencephalography were also unremarkable. A craniotomy was performed. Lower right. A diagram of the operative findings shows a small tumor mass extending from the intracranial end of the optic canal into the canal itself, with severe compression of the left optic nerve. The mass was adherent to and appeared to arise from the optic nerve sheath. Biopsy showed a meningioma. There is an increased prevalence of meningioma in patients with optic disc drusen. Although loss of visual acuity and visual field may occur in patients with optic disc drusen, when the defects are progressive and seem out of proportion to the ophthalmoscopic findings, the possibility of a meningioma or similar lesion compressing the optic nerve should be considered. Such patients should have a workup that includes plain skull X-rays with optic foramina views, optic canal polytomography, computerized tomography, cerebral angiography, and pneumoencephalography. In the face of progressive visual acuity loss, increasing peripheral visual field defect, and unilateral optic atrophy with normal neuroradiologic studies, an exploratory craniotomy may be necessary to find the small intracanalicular meningioma that may be present. Slide 48. Optic disc drusen and retinitis pigmentosa. This 32-year-old female complained of progressive visual loss that was worse at night. Visual acuity was 20/30 right eye and 20/40 left eye. Color vision was defective bilaterally and pupils were sluggish. Visual fields showed bilateral ring scotomas and mild peripheral constriction. Upper left and upper right. The right and left optic discs have irregular margins and contain numerous glistening drusen. Peripapillary atrophy is present, and the retinal arteries are markedly attenuated. Lower left and lower right. The periphery of both fundi contain many areas of hyperpigmentation in a bone spicule pattern. An electroretinogram showed marked diminution of both photopic and scotopic components, supporting a diagnosis of retinitis pigmentosa. The prevalence of optic disc drusen in patients with retinitis pigmentosa is higher than that in the normal population. Progressive visual field loss and night blindness in a patient with optic disc drusen should alert the physician to the possibility of concurrent retinitis pigmentosa. An electroretinogram will establish the diagnosis. We now leave the elevated disc anomalies that simulate optic disc edema and consider other types of anomalous optic discs. Slide 49. Optic disc coloboma. This 24-year-old female had poor vision in her right eye since birth. Visual acuity was 10/200 in the right eye and 20/20 in the left eye. Upper left. The right optic disc is markedly abnormal. Normal nerve tissue is confined to a small superior wedge from which the superior retinal vessels arise. Normal nerve fibers can be seen in the superior region only. The rest of the optic disc structure is composed of a large, deep cavity. Inferior retinal vessels emerge from the inferior wall of the cavity, but no nerve fiber layer is seen inferiorly. The macula shows marked pigment epithelial changes. Upper right. The visual field, right eye, shows an inferior island of vision corresponding to the remaining normal superior retinal nerve fibers. Lower left. A histologic section from a similar case demonstrates that the optic nerve contains a large, crater-like defect. The optic nerve on one side of the defect is composed only of collagenous connective tissue. On the other side of the defect, the optic disc is normal. Lower right. An artist's sketch illustrates the coloboma with abnormal connective tissue extending into the retrolaminar optic nerve on one side of the defect and normal neural tissue on the other side. The coloboma is one of the common malformations of the optic disc. It is a large excavation that occurs when there is abnormal closure of the fetal fissure. In most cases, optic disc colobomas are isolated phenomena, not associated with other central nervous system abnormalities. They are, however, almost always associated with decreased visual acuity and an abnormal visual field. Slide 50. Optic pit. This 41-year-old female was asymptomatic and had no history of visual acuity loss in either eye. The left eye was normal. The right eye had 20/25 acuity, normal color vision, and a small paracentral scotoma. Upper left. An oval, gray excavation is located at the mid-temporal aspect of the right optic disc. No vessels are seen in the concavity. The macula and retinal vessels are normal. Upper right. A fluorescein angiogram shows vascular fluorescence from within the base of the concavity. Lower left. 10 minutes following dye injection, there is marked hyperfluorescence from the base of the lesion. Lower right. A histologic section from a similar case shows a crater-like defect or pit at the temporal aspect of the optic nerve. The optic pit is another congenital anomaly that probably results from abnormal closure of the fetal fissure. Slide 51. Optic pit with serous retinal detachment. This 30-year-old female noted blurred vision in her left eye for 1 month. The right eye was normal. The left eye had 20/40 visual acuity and a secocentral scotoma. Upper left. A grayish optic pit is seen temporally in the left disc. A sensory retinal detachment extends temporally from the disc and includes the macula. Yellow precipitates are present on the posterior surface of the detached sensory retina. Upper right. A fluorescein angiogram shows late hyperfluorescence from the base of the pit, but no accumulation of dye under the detached sensory retina. The majority of patients with optic pits are asymptomatic. Visual loss occurs in fewer than 25% and is usually due to serous detachment of the sensory retina. No treatment was recommended for this patient, and she maintained 20/40 visual acuity. Her sensory detachment eventually flattened spontaneously. Some authors have advocated photocoagulation for serous retinal detachments associated with optic pits. Lower left. This 22-year-old male had a long history of intermittent blurred vision in his right eye. Visual acuity right eye was 20/60. The right optic disc has a temporal pit. A serous detachment of the sensory retina extends into the macula. Because of the long-standing detachment, the sensory retina has become thin and cystic. Xenon arc photocoagulation was applied to the temporal border of the pit in an effort to seal the sensory retina and pigment epithelium to the optic disc border. 2 months later, there was some reabsorption of subretinal fluid, and visual acuity improved from 20/60 to 20/40. 5 months after photocoagulation, visual acuity again fell to 20/60, and fluid reaccumulated beneath the macula. Additional photocoagulation was applied, but visual acuity remained at 20/60, and the retina remained detached. There is no evidence that photocoagulation is useful in patients with serous retinal detachments associated with optic pit, and we do not recommend its use. Lower right, the origin of subsensory retinal fluid is unknown. The artist's sketch illustrates the three sources that have been postulated. Number 1, liquid vitreous flows through the pit to enter the subsensory retinal space. Number 2, subarachnoid fluid migrates through abnormal channels in the nerve head to gain access to the subsensory retinal space. And number 3, abnormal vessels within the base of the optic pit leak fluid into the subsensory retinal space. Slide 52. Central optic pits. This 45-year-old female complained of decreased vision in her left eye. Visual acuity was 20/25 right eye and 20/60 left eye. Upper left and upper right. Both optic discs contain a small, central, gray excavation. The retinal vessels enter the eye at the borders of these excavations. Lower left and lower right. The visual fields show bilateral, absolute arcuate scotomas. Although most optic pits are located at the mid-temporal or inferior temporal margin of the disc, they may also be located in a central position. Visual field defects in patients with central optic pits include arcuate scotomas, enlarged blind spots, and quadrantinopic defects. Slide 53. Optic nerve hypoplasia. This 1-year-old boy was noted by his parents to ignore his surroundings. He was otherwise healthy and had normal developmental milestones. He blinked to a bright light, but his pupils were sluggish. Skull X-rays and emiscan were normal. Upper left and upper right. Both optic discs are extremely small and circular, and are surrounded by a ring of hypopigmentation. The retinal vessels emerge from the center of the discs and are normal. Lower left. A longitudinal section through the optic nerve in a similar case demonstrates hypoplasia of the disc and the retrolaminar optic nerve. The retinal ganglion cell layer is absent, and the retinal pigment epithelium and choroid are incompletely developed. Lower right, the artist's sketch of a hypoplastic optic nerve shows the relative size of the nerve and disc in relationship to the surrounding area. Note that the area surrounding the optic disc is relatively hypopigmented due to hypoplasia of retinal pigment epithelium. Hypoplasia of the optic nerve is seen in otherwise normal individuals and in patients with other central nervous system abnormalities. The condition is usually bilateral. Visual acuity is usually impaired, but in some cases may be normal. Visual field abnormalities include cecocentral scotomas, hemianopias, and altitudinal defects. The typical fundus picture, as seen in this patient, is a small optic disc surrounded by a halo of hypopigmented tissue, the double ring sign, and normal retinal vessels. Slide 54. Optic nerve hypoplasia with visual field defects and normal visual acuity. This asymptomatic 30-year-old female was found to have bilateral inferior altitudinal field defects on routine eye examination. Visual acuity was 20/15 in each eye, and color vision was normal. Upper left and upper right. The optic discs are small, but the retinal vessels are normal. Both discs are surrounded by an area of hypopigmentation. Lower left and lower right. Both visual fields show inferior altitudinal defects. The patient's mother has diabetes mellitus, and the patient's birth weight was 9 pounds. Optic nerve hypoplasia has been reported as an isolated finding in children of diabetic mothers. All patients have had bilateral optic nerve hypoplasia, good visual acuity, and altitudinal visual field defects. The occurrence of this phenomenon suggests that maternal influence plays a role in some cases of optic nerve hypoplasia. Slide 55. Septo-optic dysplasia. This 16-year-old male had 2100 visual acuity in both eyes. He was small for his age and had horizontal nystagmus. Upper left and upper right. Both optic discs are small and are surrounded by a halo of hypopigmented tissue. No central optic cup is seen in either eye. The retinal vessels are normal. Lower left. A pneumoencephalogram demonstrates absence of the septum pellucidum, which normally separates the lateral ventricles. Lower right. For comparison, a normal pneumoencephalogram shows the lateral ventricles separated by the septum pellucidum. Optic nerve hypoplasia may occur as an isolated phenomenon or as part of more generalized central nervous system maldevelopment. This patient demonstrates the syndrome of septo-optic dysplasia, characterized by short stature, nystagmus, endocrine abnormalities, and optic disc hypoplasia. Early diagnosis in patients with this syndrome is important since replacement of deficient growth hormone may result in normal skeletal growth. Slide 56, optic nerve dysplasia and basal encephalocele. This 52-year-old male had short stature and a history of decreased vision in his right eye since birth. Visual acuity was 3/200 right eye and 20/20 left eye. Upper left. The right optic disc is markedly dysplastic and is surrounded by hypo and hyperpigmentation. Upper right. A reddish-brown, soft tissue mass is seen in the right nasopharynx. Lower left. Basal skull X-ray demonstrates a large defect in the bony floor of the skull. Lower right. Basal polytomography demonstrates a soft tissue mass protruding through the defect in the base of the skull. The association of basal encephalocele and optic disc anomalies was first described in 1968. Patients with this syndrome typically have short stature, a flattened nasal bridge, hypertelorism, and a cleft palate or cleft lip. The possibility of basal encephalocele should be considered in any patient with congenital abnormality of the optic disc. Occasionally, encephaloceles have been mistaken for nasal polyps or enlarged adenoids, and biopsy in such cases has resulted in catastrophe. Slide 57. Optic disc anomalies associated with basal encephalocele. This slide illustrates 5 congenital anomalies of the optic disc that may be associated with basal encephalocele. Upper left, severe optic dysplasia. Upper center, optic nerve hypoplasia. Upper right, optic pit. Lower left, coloboma of the optic disc. Lower center, the morning glory syndrome. Lower right, the artist's sketch demonstrates that the bony defect involved in basal encephalocele is in the base of the skull anterior to the pituitary fossa. The sketch illustrates how the basal encephalocele may present as a mass in the nose or nasopharynx. Slide 58, the tilted optic disc syndrome. This 35-year-old female was found to have bitemporal visual field defects and abnormal optic discs on a routine examination. Visual acuity was 20/25 OU. Pupils were normal. Upper left and upper right. Both optic discs have an exaggerated oval appearance with the vertical axis directed obliquely. The upper temporal portion of the disc lies anterior to the lower nasal portion. The retinal vessels emerge from the upper aspect of the disc rather than centrally or slightly on the nasal side, and proceed nasally before turning temporally. Inferior to the actual disc is a hypopigmented conus. Lower left. The visual fields show superior bitemporal defects. Note that the defects do not respect the vertical midline. Lower right. A histologic section from another patient demonstrates the extreme oblique entrance of the optic nerve into the eye. This patient represents an example of the tilted optic disc syndrome, sometimes called situs inversus. It is of major importance for 2 reasons. First, the oblique nature of the disc, especially when associated with myopic astigmatism, often causes confusion between a disc anomaly and optic disc edema. Second, the bitemporal field defects seen in these patients are often interpreted as indicative of a chiasmal lesion. It should be noted, however, that although the visual fields generally exhibit a bitemporal pattern, the defects are not truly hemianopic, since the smaller isopters do not obey the vertical midline. This is in marked contrast to the true bitemporal hemianopia caused by chiasmal compression. Although the visual field defects have been ascribed to the associated myopic astigmatism that is generally present in these patients, a localized hypoplasia of retina and choroid may be responsible. Slide 59. Myelinated nerve fibers. This asymptomatic 34-year-old female had 20/30 visual acuity. Upper left, the right optic disc is obscured by dense white tissue in a striated pattern that obscures the retinal vessels as they leave the optic disc. Upper right, a fluorescein angiogram shows no retinal vascular abnormalities. Lower left, the right eye has a full visual field with an enlarged blind spot. Lower right, an artist's sketch demonstrates myelinated nerve fibers above and below the retinal vessels. Myelination of the anterior visual system begins at the lateral geniculate body in the 7th month of gestation and proceeds towards the eye. Normally, myelination stops at the lamina cribrosa. Patients with intraocular nerve fiber myelination may have abnormal rests of oligodendroglia present in the retina during embryogenesis. Myelinated nerve fibers follow the pattern of normal nerve fibers and extend peripherally as irregular, feather-shaped patches. The retinal vessels may or may not be obscured by patches of myelination. Most patients with myelinated retinal nerve fibers have normal visual acuity. Slide 60. Patterns of retinal nerve fiber myelination. This slide shows patterns of intraocular myelination in 4 patients. Upper left. A common pattern is that of extensive myelination that begins at the optic disc and extends peripherally in all directions. Upper right, small patches of peripapillary nerve fiber myelination may also be seen. Lower left, occasionally, retinal nerve fiber myelination begins at the disc and extends peripherally in one direction only. This patient has extensive myelination of the superior and inferior temporal arcuate bundles. Lower right, although myelination is most common adjacent to the optic disc, patches of peripheral myelination may be seen. We now leave congenital anomalies of the optic disc and begin our discussion of optic atrophy. Slide 61. Optic atrophy. Although there are many causes of optic atrophy, the clinician's main concern is whether or not a compressive lesion is responsible. For this reason, early diagnosis is imperative if vision is to be saved. In an effort to diagnose early optic atrophy, we emphasize changes in the peripapillary retinal nerve fiber layer. Interruption of axonal function in the anterior visual pathway causes visible morphologic changes. Upper left. A schematic drawing shows that the normal peripapillary retinal nerve fiber layer has fine, radially oriented striations that partially obscure the retinal vessels. Upper right, after focal axonal loss, slits or grooves appear in the peripapillary arcuate zones that represent thinned or absent nerve fiber tissue. These areas are best seen 1 to 2 disc diameters away from the optic disc using red-free illumination. Lower left. When nerve fiber layer destruction continues, the optic disc becomes pale. The artist's sketch shows areas in which the normal striated pattern of the nerve fiber layer is markedly reduced. These areas have a dark appearance in red-free light. In cases of sector pallor of the optic disc, a corresponding area of nerve fiber layer dropout is visible. Lower right. In diffuse, severe axonal destruction, not only is the optic disc pale, but there is extensive loss of normal peripapillary retinal striations. The retinal vessels are seen more clearly due to the absence of overlying retinal nerve fibers. Slide 62. Optic atrophy from trauma. This 16-year-old female was struck in the left orbit with a screwdriver 4 years previously. She had a conjunctival laceration but no other obvious ocular damage. Recently, she became aware of temporal field loss in her left eye. The right eye was normal. The left eye had 20/20 visual acuity, mildly diminished color vision, and an afferent pupillary defect. Upper left. the right optic disc is normal. Upper right, the left optic disc shows diffuse pallor with loss of the nerve fiber layer. Lower left, there is extensive visual field loss, most marked temporally. Skull X-rays with views of the optic foramina were normal. Differential diagnosis included a compressive mass of the left optic nerve, such as a meningioma, versus a traumatic optic nerve contusion. The patient has been followed for 2 years without change in visual acuity or visual fields. The optic atrophy in this patient is probably due to a contusion injury of the intraorbital optic nerve, resulting in mild intradural hemorrhage and ischemia. Intradural optic nerve hemorrhages may cause visual loss by direct pressure on the nerve or by interfering with the blood supply of vessels passing through the dura and into the nerve itself. It is not uncommon for optic nerve injury to occur from orbital puncture wounds that are initially believed to be superficial. Lower right, the artist's sketch shows the presumed pathway and mechanism of optic nerve damage from orbital puncture wounds. Slide 63, optic atrophy from ophthalmic artery aneurysm. This 58-year-old female had noted slowly progressive loss of vision in the right eye for 3 years. The right eye had 2400 visual acuity, defective color vision, and an afferent pupillary defect. The right visual field showed only a small temporal island of vision. The left eye was normal. Upper left, the right optic disc is pale, and there are defects in the peripapillary retinal nerve fiber layer. Upper right, the left optic disc and peripapillary retina are normal. The history of slowly progressive, unilateral visual loss with optic atrophy suggested a mass lesion compressing the right optic nerve. Skull X-rays and optic canal polytomograms were normal. Lower left, a cerebral angiogram demonstrates a large aneurysm arising from the right internal carotid artery at the origin of the ophthalmic artery. Lower right, the artist's sketch of the ophthalmic artery aneurysm shows how it may compress the optic nerve and cause optic atrophy. Although tumors are the most common cause of optic nerve or chiasmal compression, aneurysms and inflammatory lesions can also compress the anterior visual pathways, resulting in slowly progressive visual loss from optic atrophy. Slide 64, optic atrophy and ischemia. This 62-year-old female stated that she had suddenly lost all vision in her right eye 6 months previously. Visual acuity in the right eye was hand motions in the superior temporal quadrant only, and there was a right afferent pupillary defect. Visual acuity in the left eye was 20/20 with a normal visual field. The patient's blood pressure was mildly elevated. Upper left, the right optic disc is diffusely pale, the retinal arteries and veins are narrowed, and the peripapillary retinal nerve fiber layer is absent. Upper right, the left optic disc, peripapillary retinal nerve fiber layer, and retinal vessels are normal. Unilateral optic atrophy in an elderly patient is a common ophthalmologic problem. In almost all cases, the patient's history is the most important factor in determining the etiology of the atrophy. The most common causes of optic atrophy in adults are tumors, trauma, and ischemia. This patient had no history of trauma, and the sudden onset of the visual deficit and the lack of subsequent progression made a vascular etiology most likely. Once giant cell arteritis is effectively ruled out by a careful history, examination, and a normal sedimentation rate, no further evaluation is necessary except for a general medical checkup to rule out systemic diseases such as hypertension, diabetes mellitus, or anemia, and a regular follow-up to document the stability of the patient's visual acuity and visual fields. Many ophthalmologists prefer to obtain a skull X-ray in all cases. However, the number of times that this will show evidence of a mass lesion is sufficiently rare so as not to warrant this study in all cases. The 2 ischemic lesions most likely to have caused optic atrophy in this patient's eye are central retinal artery occlusion and ischemic optic neuropathy. Lower left, a histologic section of the retina from a patient with a central retinal artery occlusion demonstrates complete loss of the ganglion cell and nerve fiber layers and partial loss of the inner nuclear layer. Lower right, the artist's sketch illustrates that occlusion of the central retinal artery does not affect the outer retinal layers that are normally supplied by the choriocapillaris. Slide 65. Sector optic atrophy from ischemia. This 40-year-old female noticed difficulty seeing with her right eye 4 months previously. The right eye had 20/40 visual acuity, reduced color vision, and an afferent pupillary defect. The left eye was normal. Upper left. The right optic disc shows superior temporal pallor with extensive loss of the superior nerve fibers. The inferior nerve fibers are easily seen as diffuse, radially oriented striations. Superior retinal vessels are seen in sharp detail due to loss of overlying nerve fibers. Upper right. The visual field, right eye, shows an inferior altitudinal defect corresponding to the loss of superior nerve fibers. Lower left. The red-free composite clearly demonstrates the loss of superior retinal nerve fibers. Lower right, an artist's sketch of the red-free photograph shows the area of remaining normal nerve fibers. Sector optic atrophy is most often ischemic and is due to either systemic vascular disease or trauma. Patients with a history of sudden visual field or acuity loss and sector optic pallor can be followed at regular intervals without an extensive neuroradiologic evaluation. This patient has been followed for 3 years without change in visual acuity or visual fields. Slide 66. Optic atrophy from retrobulbar optic neuritis. This 34-year-old male was in good health until 3 months prior to evaluation, when he developed severe pain behind the right eye that was worse on movement of the eye and was associated with a diffuse haze over the entire field of vision in the right eye. Visual acuity was counting fingers, right eye, and 20/20, left eye. The right eye had an afferent pupillary defect, reduced color vision, and a dense central scotoma. The left eye was normal. The patient was started on 40 milligrams of prednisone daily, and within 1 week, visual acuity had returned to 20/20 in the right eye. Steroids were tapered, but acuity dropped to 20/60 on the right, with return of retrobulbar pain. Steroids were resumed, and right eye visual acuity rapidly returned to 20/20, after which steroids were tapered over a 3-week period. Visual acuity stabilized at 20/25 right eye and 20/15 left eye. Color vision was normal in both eyes, but there was a subjective decrease in color brightness on the right. A subtle right afferent pupillary defect persisted, and the right visual field showed a small central scotoma to red. Upper left. The right optic disc shows temporal pallor. Dark slits are present in the superior and inferior arcuate nerve fiber bundles. Upper right. The left optic disc is normal, as is the peripapillary retinal nerve fiber layer. Lower left. Arrows point to slit-like defects in the superior arcuate temporal bundle in a red-free photograph of the right eye. Lower right. The visual field in the right eye demonstrates an inferior arcuate scotoma extending nasally along the horizontal meridian and corresponding to the dark grooves that represent focal axon destruction. Superior arcuate defects are also present. This patient is presumed to have had at least 2 episodes of retrobulbar optic neuritis. Up to 50% of patients with retrobulbar optic neuritis in the age range from 15 to 45 years will eventually develop other symptoms and signs suggestive of a demyelinating process. Although optic atrophy has been considered the cardinal sign of visual system involvement in demyelinating disease, it is clear from careful electrophysiological testing and direct ophthalmoscopy that many patients with demyelinating disease have evidence of damage to the visual system, such as an abnormal visual evoked cortical potential or defects in the peripapillary retinal nerve fiber layer despite lack of visual symptoms. Slide 67. Optic atrophy from recurrent retrobulbar optic neuritis. This 32-year-old male experienced the sudden onset of severe pain behind the left eye, followed 2 days later by loss of central vision in that eye. The right eye was normal. the left eye had visual acuity of 2200 with defective color vision, a central scotoma, and an afferent pupillary defect. Neurologic examination was unremarkable, and no further studies were performed. Upper left. The left optic disc is normal. Over the next week, the patient's vision improved to 20/25. However, 3 months later, he again experienced visual loss in the left eye, and visual acuity was recorded as 2400. Upper right. At the time of the patient's second episode of visual loss, there are nerve fiber bundle defects in the superior and inferior arcuate areas, and there is definite temporal optic disc pallor. Lower left. 6 months later, visual acuity has returned to 20/60 in the left eye, with a small central scotoma. In spite of visual improvement, the left optic disc shows increased temporal pallor. Lower right. 1 year after initial visual loss, visual acuity in the left eye is 20/60 and there is prominent optic atrophy. Although most cases of optic neuritis resolve without residua, some patients, particularly those who have recurrent attacks, may develop irreversible visual acuity loss with nerve fiber bundle defects and optic atrophy. Patients who have a single episode of unilateral retrobulbar optic neuritis have about 1 chance in 5 of developing other signs and symptoms of multiple sclerosis, while patients who have recurrent attacks have a significantly higher incidence of multiple sclerosis. Clinical trials have shown that steroid treatment does not alter the eventual visual outcome in patients with optic neuritis. Slide 68. Optic atrophy from congenital hydrocephalus. This 1-year-old black male was noted to have rapid head enlargement since birth. His mother observed that he did not follow objects. Both pupils reacted sluggishly to light. Upper left and upper right. Both optic discs are diffusely pale with retinal nerve fiber layer loss. The retinal vessels are normal. Skull X-rays showed changes consistent with chronic increased intracranial pressure. Lower left. An ME scan demonstrates marked enlargement of the ventricular system. A diagnosis of congenital hydrocephalus was made and ventriculo-atrial shunt was performed. Lower right. An ME scan 4 months after shunt demonstrates normal ventricular size. The most common causes of bilateral optic atrophy in childhood include congenital hydrocephalus, central nervous system degenerative diseases, trauma, and tumors. Patients with congenital hydrocephalus are most often identified early in life because of progressively increasing head circumference. The fundi in these patients may be normal or may show papilledema or optic atrophy, depending upon the severity of the disease and the status of the skull sutures. Early diagnosis of this condition may result in preservation of visual function and in a better prognosis for survival. Slide 69. Optic atrophy and craniopharyngioma. This 9-year-old male complained of headaches for 3 months. Visual acuity was 20/50 OU with diminished color vision and normal pupils. Upper left and lower left. Both optic discs are pale, with the pallor restricted to a horizontal, band-shaped area crossing the disc. The upper and lower poles of both discs have a normal pink color, and the superior and inferior arcuate nerve fiber bundles are seen well in both eyes. Upper center. The visual fields show bitemporal hemianopia. A compressive lesion involving the optic chiasm was suspected. Lower center. A lateral tomogram of the sella turcica demonstrates a J-shaped sella. The arrow points to calcification in the suprasellar region. Upper right. An ME scan demonstrates a dense, partially calcified mass in the suprasellar region. Craniotomy confirmed the presence of a large suprasellar craniopharyngioma that was subtotally excised. Lower right. An artist's sketch of the suprasellar craniopharyngioma shows its relationship to the chiasm and optic nerves. Gliomas and craniopharyngiomas are the most common childhood tumors causing bilateral optic atrophy by direct involvement of the optic nerves or chiasm. Craniopharyngiomas account for about 3% of all intracranial tumors. Although these tumors usually occur in children, They have an increased incidence in the 6th and 7th decades of life. The size and position of the tumor dictates the nature of the symptoms, which may range from headaches and visual loss to obesity, diabetes insipidus, and disturbed carbohydrate metabolism. Increased intracranial pressure and papilledema may occur due to obstruction of the third ventricle. In these patients, the diagnosis may be suspected by bitemporal visual field loss and bilateral optic atrophy, and may be confirmed by plain skull X-ray, which shows suprasellar calcification in approximately 50% of cases. Slide 70, optic atrophy and pituitary adenoma. This 35-year-old male complained of difficulty seeing in the temporal field of each eye. Visual acuity was 2200 right eye and 20/20 left eye. Color vision was markedly diminished in both eyes, and there was a right afferent pupillary defect. Upper left, the right optic disc is diffusely pale with generalized loss of nerve fibers. Upper right, the left optic disc also has mild pallor with loss of nerve fibers. Arrows point to arcuate nerve fiber bundles in the left fundus. Note that these are not seen in the right fundus. Lower left, the visual fields show an incomplete bitemporal hemianopia. Progressive visual acuity loss and bitemporal field defects suggested a compressive lesion of the optic chiasm. A skull X-ray showed an enlarged sella turcica. Lower right, an ME scan demonstrates a large, dense mass in the suprasellar region. A pituitary adenoma was removed transsphenoidally. Postoperatively, visual acuity improved to 20/30 in the right eye and to 20/15 in the left eye, but color vision remained diminished in both eyes. A right afferent pupillary defect persisted, and the visual fields remained relatively unchanged. In adults, the most common tumor causing chiasmal compression is a non-secreting pituitary adenoma with suprasellar extension. Any patient with an enlarged sella turcica should undergo careful visual field testing to determine if there is evidence of chiasmal compression and a complete endocrinologic evaluation. Slide 71, optic atrophy and falx meningioma. This 69-year-old male had noted slowly progressive visual loss for at least 3 years. Recently, he had developed personality changes. Visual acuity was hand motions right eye and light perception left eye. Visual fields show small nasal islands of vision. Upper left and upper right. Both optic discs are atrophic and the retinal vessels are narrowed. The history of slow progression suggested a compressive lesion involving either the optic chiasm or both optic nerves. Lower left, an ME scan demonstrates a large frontal mass on both sides of the falx cerebri, surrounded by mild cerebral edema. There is no midline shift. This picture is most consistent with a meningioma arising from the falx. Although glioblastomas of the frontal region may cause papilledema by either mass effect or increased cerebrospinal fluid protein, meningiomas in this region generally cause progressive optic atrophy by direct compression of both optic nerves. Lower right, the artist's sketch shows the presumed relationship between a falx meningioma and the anterior visual system. A history of slowly progressive bilateral loss of visual acuity and visual field should alert the physician to the possibility of an intracranial mass compressing either the optic chiasm or both optic nerves. The most common lesions that produce this clinical picture are pituitary adenoma, craniopharyngioma, meningioma, and suprasellar aneurysm. Slide 72. Hemianopic optic atrophy. In addition to focal and diffuse nerve fiber loss, atrophy of fibers in the optic tract or the lateral geniculate body produces retrograde or Wallerian degeneration of both crossed and uncrossed fibers that results in predictable patterns of nerve fiber loss and optic atrophy in the ipsilateral and contralateral fundi. Upper left, the artist's sketch shows the pattern of nerve fiber layer dropout and optic atrophy in the right fundus produced by a lesion of the left optic tract or lateral geniculate body. Upper right, a patient with a left optic tract or geniculate lesion will have a temporal hemianopia in the right eye. Lesions involving the optic tract or lateral geniculate body produce a temporal hemianopia in the contralateral eye from destruction of crossed nasal fibers. Since these fibers include nasal macular fibers that enter directly into the temporal portion of the optic disc, as well as nasal peripheral fibers that enter the nasal portion of the optic disc, the resulting optic atrophy takes the form of a transverse band across the disc surface. This phenomenon has been described as band atrophy. Lower left. The artist's sketch shows the pattern of nerve fiber loss and optic atrophy in the left eye of a patient with left optic tract or lateral geniculate lesion. Loss of temporal fibers results in diminution of reflexes from the superior and inferior arcuate temporal bundles and a more vertically oriented central disc pallor. Lower right, a patient with a left optic tract or geniculate lesion will have a nasal hemianopia in the left eye. The fundus ipsilateral to a tract or lateral geniculate lesion also has a distinct appearance. Loss of uncrossed temporal retinal fibers produces a nasal hemianopia. Since most of the temporal retinal fibers enter the superior and inferior temporal arcuate bundles, destruction of these temporal fibers leads to thinning of the arcuate bundles with loss of normal highlights when compared to the contralateral eye. The disc pallor is more pronounced in the superior and inferior temporal areas of the disc. This pattern occurs not only in optic tract and geniculate lesions, but also as a result of transsynaptic degeneration from retrogeniculate lesions that are acquired in early life. Although the pattern is less obvious in such patients, it is the same as described for pregeniculate lesions. Recognition of hemiretinal patterns of nerve fiber layer loss and optic atrophy may be of utmost importance in determining the nature and localization of the process that has caused that atrophy. Slide 73. Hemianopic atrophy from optic tract lesion. This 35-year-old male developed a slowly progressive left hemiparesis and a left homonymous hemianopia. Visual acuity was 20/20 OU. Upper left. The right optic disc shows mild temporal pallor with some subtle loss of nerve fibers in the superior and inferior arcuate regions. Upper right. An artist's sketch of the right fundus shows loss of temporal retinal fibers resulting in temporal atrophy of the disc and a nasal hemianopia. Lower left. The left optic disc shows a horizontal band of pallor resulting from loss of nasal macular and nasal peripheral retinal fibers. Lower right. An artist's sketch of the left fundus shows loss of nasal fibers and a horizontal band of pallor of the left optic disc. This picture typifies the hemianopic atrophy seen in patients with lesions of the right optic tract or right lateral geniculate body. Slide 74. Hemianopic atrophy and optic tract lesion continued. Upper left. The visual field from the patient described in slide 73 shows a complete left homonymous hemianopia. Upper right, an EMI shows a large calcified mass in the region of the right thalamus. At craniotomy, this was felt to be an old calcified arteriovenous malformation. Lower left. The artist's sketch shows the relationship of the AV malformation to the right optic tract. Lower right. An optic nerve cross-section showing a horizontal band of atrophy outlined by arrows is the histologic correlation of the band atrophy seen in patients with a temporal hemianopia from a contralateral optic tract or lateral geniculate lesion. Slide 75. Hemianopic atrophy from transsynaptic degeneration. Shortly after birth, this 9-year-old male sustained an occipital intracerebral hematoma. 5 years later, he was noted to have bilateral optic atrophy and visual field defects. Visual acuity was 20/20 OU. Upper left. The right optic disc shows mild pallor, worse temporally than nasally. The pallor is more prominent at the superior and inferior poles of the disc, and no temporal arcuate nerve fiber bundles are visible. Upper right. The left optic disc is also pale, but the pallor is restricted to a horizontal area across the disc surface. Note that the superior and inferior temporal poles of the left disc are normal in appearance, and that the arcuate nerve fiber bundles are easily seen. Lower left, the visual field shows a complete left homonymous hemianopia. It was initially assumed that the patient had suffered direct damage to the right optic tract or lateral geniculate body. Lower right, an emiscan demonstrates a large lucency in the right occipital region. On other cuts of the emiscan, the lucent area communicates with the occipital horn of the right lateral ventricle. In this patient, transsynaptic degeneration has produced a striking picture of hemianopic optic atrophy associated with an acquired occipital lobe defect. Slide 76. Toxic optic neuropathy. This 34-year-old male complained of trouble seeing and was found to have visual acuity of 2200 OU with decreased color vision. Upper left and upper right. Both optic discs show marked temporal pallor with loss of the nerve fiber layer in the papillomacular bundle. Lower left. The visual fields show bilateral secocentral scotomas. A careful history revealed that the patient imbibed approximately 1 pint of whiskey per day. He ate 1 meal a day consisting of canned beef and occasional potatoes or bread. He ate no fruit or vegetables. Although serum folate and vitamin B12 levels were normal, the patient was treated with intramuscular vitamin B12 and folic acid. 1 month after beginning therapy, his visual acuity had improved to 20/40 in both eyes with smaller secocentral scotomas. Color vision remained diminished, and the discs remained pale. Bilateral loss of visual acuity and color vision, combined with bilateral secocentral scotomas, usually indicates a toxic optic neuropathy. Drugs such as antabuse, isoniazid, placidil, and ethambutol may cause such a process. Although the etiology of the bilateral retrobulbar optic neuropathy that occurs in alcoholics with poor nutrition is unknown, patients with malabsorption syndromes may develop optic neuropathy. Although the etiology of the bilateral retrobulbar optic neuropathy that occurs in alcoholics with poor nutrition is unknown, patients with malabsorption syndromes may develop optic neuropathies that are clearly reversible when treated with vitamin B12. Lower right. An optic nerve cross-section from another patient with nutritional optic neuropathy shows atrophy of temporal fibers from the papillomacular bundle. Slide 77. Neurosyphilis and the ocular fundus. This slide illustrates 4 ways that syphilis can affect the optic nerve, retina, and choroid. Upper left and lower left. This 65-year-old male had a 10-year history of bilateral progressive visual loss. Visual acuity was 20/40 OU with diminished color vision. Visual fields showed marked constriction and bilateral central scotomas. Both optic discs show temporal pallor. The history in this patient suggested an intracranial mass lesion. However, skull X-rays, polytomography of the sella and sphenoid regions, and emiscan were all normal. STS was positive in serum and cerebrospinal fluid. This patient's progressive optic atrophy was presumably secondary to neurosyphilis. There was no change in either visual acuity or visual field after a therapeutic course of penicillin. Syphilis may involve the optic nerve, choroid, or retina in a variety of ways. Anterior as well as retrobulbar optic neuritis may occur, and bilateral optic atrophy may develop. By the time extensive optic atrophy is present, antibiotic treatment will not improve visual acuity or fields. Upper center and lower center. This 35-year-old male with a positive serum and spinal fluid STS had normal visual acuity, unilateral optic disc edema, and CSF pleocytosis. The patient's optic disc edema resolved completely with appropriate antibiotic therapy. In some patients with neurosyphilis, an optic perineuritis involving the meningeal sheaths results in optic disc edema with normal visual acuity. Such cases are usually bilateral, but may be unilateral as in this patient. Spinal fluid pressure is normal, but there is often a pleocytosis. Prompt treatment with antibiotics generally results in resolution of optic disc edema with preservation of normal visual acuity and fields. Upper right. This 70-year-old male with documented neurosyphilis had no light perception in the right eye. Note the pale atrophic disc, narrow retinal vessels, and extensive peripapillary pigmentary change. This fundus picture has been called angiopathic retinitis and is characterized by marked optic atrophy and severe retinal scarring with pigmentary degeneration. Lower right. This asymptomatic 64-year-old male had visual acuity of 20/20 OU. His left eye was normal. The nasal fundus in the right eye has extensive pigmentary change, including pigment migration into the retina. There is a dense temporal field defect corresponding to the changes observed in the nasal fundus. Serum STS was positive. ERG was abnormal in the right eye, but normal in the left eye. There was no family history of retinitis pigmentosa. In some patients with neurosyphilis, the fundus may show a picture similar to that of retinitis pigmentosa without optic nerve involvement. In any patient who presents with optic atrophy, particularly when there is retinal pigmentary alteration, the possibility of neurosyphilis should be considered. In such cases, serum and spinal fluid STS and FTA-ABS should be obtained. Slide 78. Optic atrophy and optociliary shunt vessels. In most cases of optic atrophy, it is the patient's history rather than the optic disc appearance that helps determine the etiology. The triad of blindness, optic atrophy, and optociliary shunt vessels, however, has been identified as an indicator of chronic compression of the intraorbital or intracanalicular optic nerve. This compression is most often due to a meningioma, but has been noted in patients with optic nerve glioma, optic nerve sheath cyst, and in post-papilledema optic atrophy. Upper left. This 49-year-old female developed decreased vision in her left eye 9 years previously. An exploratory craniotomy revealed an intracanalicular meningioma. Postoperatively, the patient was blind in her left eye. The left optic disc is atrophic, with narrow, sheathed retinal arteries and at least 4 optociliary vessels. Upper right. This 35-year-old female had progressive visual loss in her left eye. The right eye was normal. The left eye had 20/40 visual acuity, defective color vision, and an afferent pupillary defect. The optic disc is pale, and there is a single shunt vessel at its temporal margin. The patient underwent orbital exploration, at which time an arachnoid cyst of the optic nerve was discovered. Lower left. This 12-year-old female had chronic papilledema from pseudotumor cerebri. Despite therapy, visual acuity in her left eye decreased to 20/400. The left optic disc is pale, and there are several optociliary shunt vessels on the surface. It has been postulated that constriction of the central retinal vessels by a slow-growing retrobulbar mass or by chronic increased intracranial pressure fosters the development of bypass channels within the eye. The gradual obstruction results in dilatation of preformed capillaries that connect the central retinal vein and the peripapillary choroid. Lower right, an artist's sketch demonstrates the nature of optociliary shunt vessels in patients with optic atrophy and chronic compression of the optic nerve. It should be emphasized that although a sphenoorbital meningioma is the most common cause of blindness, unilateral optic atrophy, and optociliary vessels, other compressive lesions of the optic nerve may produce a similar picture. In addition, optociliary shunt vessels may also be seen in patients after central retinal vein occlusion and as a congenital anomaly in patients with normal visual acuity and visual fields. Slide 79. Leber's optic neuropathy. This 32-year-old male with no family history of eye disease noted the gradual onset of blurred vision in his left eye. At that time, the right eye had 20/15 visual acuity, normal color vision, and a full visual field, while the left eye had 20/50 visual acuity, defective color vision, a secocentral scotoma, and an afferent pupillary defect. A diagnosis of optic neuritis was made, and the patient was treated with systemic steroids. Over the next 2 months, visual acuity in the left eye initially improved slightly, and then fell to 2300. The patient's cecocentral scotoma enlarged, and he developed optic atrophy. An intracanalicular meningioma was suspected, and, despite unremarkable neuroradiologic studies that included optic canal polytomography and pneumoencephalography, the patient underwent craniotomy with unroofing of the left optic canal. The intracranial and intracanalicular portions of the optic nerve were normal. Upper left. At the time of initial visual difficulty in the left eye, the right optic disc appears normal. 1 month postoperatively, the patient noted a mild blur in his right eye. At this time, visual acuity was 20/20, with a slight diminution of color vision and a small cecocentral scotoma to red. Upper right. The right optic disc now shows mild hyperemia with blurring of the disc margin, particularly nasally. A short arrow points to a few telangiectatic vessels inferior to the disc. There is a small, flame-shaped hemorrhage, 1 disc diameter, temporal to the disc margin. Over the next 3 months, there was progressive visual loss in the right eye. Lower left. 3 months after the onset of right eye visual loss, the right optic disc is moderately hyperemic, and the peripapillary telangiectatic vessels have become more obvious. A superficial, flame-shaped hemorrhage is seen at the superior temporal pole of the optic disc. A fluorescein angiogram demonstrated no leakage from either disc or peripapillary retinal vessels. The patient's vision continued to decrease. Lower right. 1 year after the onset of visual symptoms in the right eye, and 20 months after the onset of visual symptoms in the left eye, visual acuity is 1/200th right eye and 6/200ths left eye. The right optic disc shows marked temporal pallor. The previously observed telangiectatic peripapillary vessels have disappeared. Despite a negative family history and a 7-month interval between involvement of the 2 eyes, this patient is presumed to have Leber's optic neuropathy. In most cases, the disease is transmitted as an X-linked recessive. Both eyes are generally involved, usually within a few weeks or months of each other, but occasionally as long as a year apart. Involvement of the optic disc ranges from true optic disc edema, often with superficial hemorrhages, to progressive optic atrophy. Recently, at least one form of the disease has been recognized in its acute stage by the appearance of peripapillary telangiectatic vessels associated with a pseudoedema of the optic disc. A fluorescein angiogram in such cases demonstrates no leakage from the disc or from the telangiectatic vessels. The next slide emphasizes the findings in the acute phase in Leber's optic neuropathy. Slide 80. Leber's optic neuropathy. This 19-year-old male presented with progressive loss of vision in both eyes. 3 months earlier, he had noted blurred vision in his left eye, at which time visual acuity was 20/40 with a cecocentral scotoma. A course of systemic steroids did not improve his vision. 2 months later, he noted blurred vision in his right eye. Visual acuity was 20/60 right eye and 2200 left eye. Color vision was diminished bilaterally, and there was a left afferent pupillary defect. Visual fields showed bilateral cecocentral scotomas. Upper left. The right optic disc is hyperemic. The nasal portion of the disc is obscured by a white congenital glial remnant. Arrows point to dilated telangiectatic vessels. Upper right. The telangiectatic vessels are even more apparent in this magnified red-free photograph. Lower left. The telangiectatic vessels fill with fluorescein, but do not leak. Lower right. A careful family history produced 2 male relatives with unexplained bilateral visual loss and optic atrophy. Complete workup in both patients revealed no evidence of an intracranial mass. A diagram of the pedigree indicates that this disease is transmitted as an X-linked recessive trait in this family. It is important for the clinician to recognize Leber's optic neuropathy despite the lack of specific therapy, since correct diagnosis can prevent extensive neuroradiologic evaluation and possibly even exploratory craniotomy. the occurrence of bilateral visual loss associated with cecocentral scotomas and peripapillary telangiectatic vessels is sufficient to establish the diagnosis, thereby eliminating the necessity for further evaluation. In addition to the so-called toxic optic neuropathies, Leber's is the only optic neuropathy that also produces bilateral cecocentral scotomas. This similarity in visual fields suggests that a humoral agent toxic to the optic nerve may be responsible. Finally, not all cases with Leber's optic neuropathy begin with peripapillary telangiectatic vessels and pseudoedema of the optic disc. The absence of these findings should not necessarily rule out the diagnosis. We now begin a discussion of neuro-ophthalmologic disorders that primarily involve the retina and the choroid. Slide 81. Neurofibromatosis. This 12-year-old male complained of reduced vision in his right eye. Visual acuity was 2100, with diminished color vision and a right afferent pupillary defect. Visual field showed constriction with many small scotomas to all isopters. There were 3 millimeters of proptosis of the right eye. The left eye was normal. Upper left. The right iris has multiple brown elevated nodules on its surface. Upper right. The right axilla contains many pedunculated lesions and small patches of hyperpigmented skin. Lower left. A large area of hyperpigmented skin is present on the back. Lower right. The right optic disc is edematous and hyperemic with obscuration of the retinal vessels. This patient has classic findings of von Recklinghausen's neurofibromatosis. The iris abnormalities, once felt to be true neurofibromas, are now thought to be nevi. Skin lesions include neurofibromas, which are hamartomas of peripheral nerve tissue, and café au lait spots of skin hyperpigmentation. The latter are prevalent in the groin, axillary, and truncal regions. Patients with neurofibromatosis have an increased incidence of optic nerve gliomas, meningiomas, and acoustic neuromas. The presence of proptosis, optic disc edema, and decreased vision in a patient with neurofibromatosis strongly suggests the presence of an optic nerve glioma. Slide 82. Neurofibromatosis. This 2-year-old female with known neurofibromatosis presented with proptosis of the right eye. The child did not follow objects with her right eye, and there was a right afferent pupillary defect. The left eye was normal. Upper left. The right optic disc is edematous and has an indistinct margin. A round intraretinal hemorrhage is seen adjacent to the disc. Plain skull X-rays showed an enlarged right optic foramen. Upper right. An ME scan shows a normal left orbit. The right eye is proptotic, and an arrow points to a large mass that extends from the back of the globe to the orbital apex. Orbital exploration revealed a markedly enlarged optic nerve beginning just posterior to the globe and extending to the orbital apex. The nerve was severed at the apex, and the nerve and globe were removed. Lower left. A longitudinal section shows optic disc edema and massive enlargement of the optic nerve as it emerges from the globe. Lower right, a high-power section through the optic nerve shows numerous plump astrocytes and elongated PAS-positive rod-shaped bodies. These intracellular Rosenthal fibers are found exclusively in the cell bodies and processes of astrocytes, particularly in optic nerve gliomas. We emphasize that optic nerve gliomas are hamartomas rather than true malignancies. Once a diagnosis of optic nerve glioma has been established, a patient should be followed unless cosmetic considerations necessitate removal of the tumor. We believe that in all cases, an attempt to save the eye itself should be made. It must be remembered, however, that meningiomas of the orbit can also present in similar fashion. In some cases, biopsy of the optic nerve may be necessary to differentiate meningioma from optic nerve glioma in children with neurofibromatosis. Slide 83. Tuberous sclerosis. This 15-year-old female has had seizures since birth and is mentally retarded. Upper left, there are numerous maculopapular lesions on her face. Upper right, a small patch of hypopigmented skin is present on the right arm. Lower left, the right great toe has a small, firm, non-tender lesion at the base of the nail. Lower right. Visual acuity was 20/20 OU, but there was an enlarged blind spot and an inferior arcuate field defect in the left eye. Much of the left optic disc is obscured by an elevated, yellow, glistening lesion. This patient has tuberous sclerosis, or Bournville's disease, a syndrome characterized by seizures, mental retardation, and angiofibromas of the malar region called adenoma sebaceum. Other skin lesions in this syndrome include hypopigmented skin patches, sometimes called mountain ash leaf spots, and café au lait hyperpigmented spots. Patients may also have subungual fibromas of the extremities and hamartomas of the kidneys, heart, brain, and eye. The optic disc hamartoma shown lower right has been called a giant drusen or giant glial astrocytoma. This mass is similar in nature and composition to the smaller buried drusen of the optic disc discussed in an earlier section of this volume. Tuberous sclerosis is transmitted as an autosomal dominant. Slide 84, tuberous sclerosis. This 14-year-old boy has had seizures since birth and has severe mental retardation. Upper left. The large patch of hypopigmented skin on the patient's back bears a striking resemblance in shape and size to the leaf of the mountain ash tree, upper right, from which its name was derived. These patches are pathognomonic of tuberous sclerosis. Lower left. Above the right optic disc is a well-circumscribed, elevated lesion that obscures the retinal vessels. Lower right. An EMI demonstrates a single calcified lesion that appears to be located in the wall of the right lateral ventricle. These calcified subependymal nodules apparently originate from giant cell astrocytes. They are benign, but may be responsible for seizures and may even obstruct circulation of cerebrospinal fluid, resulting in increased intracranial pressure and papilledema. Slide 85, tuberous sclerosis. The retinal lesions observed in tuberous sclerosis are varied. Upper left. The classical lesions are retinal hamartomas, generally seen in the periphery as oval or circular, white or gray, elevated lesions that obscure the retinal vessels. Upper center and upper right. The lesions appear to change with time, losing their gray-white appearance and becoming more yellow and glistening, presumably the result of increasing calcification. Lower left. The peripheral lesions may eventually have a glistening, mulberry-shaped appearance, resembling the more common, smaller optic disc drusen. Lower center. Although generally found in the periphery, these lesions may also overlie the optic disc. Lower right. Patients with tuberous sclerosis may also have peripheral, hyper, and hypopigmented choroidal lesions. The etiology of these lesions is unknown. Recognition of these fundus lesions may enable the ophthalmologist to provide a specific diagnosis in children with idiopathic seizures, mental retardation, or both. Slide 86, encephalotrigeminal angiomatosis. This 25-year-old male has had decreased vision in the left eye since birth and seizures since early childhood. Upper left. There is an extensive venous angioma of the skin involving the left upper facial region. Visual acuity is 20/20 in the right eye and hand motions left eye. There is a slight fullness to the left upper lid. Intraocular pressure is normal in the right eye and moderately elevated in the left eye. Upper right, the left optic disc shows extensive cupping with nasalization of retinal vessels, and the entire peripapillary fundus has a diffuse dusky red color. Lower left and lower right, an EMI scan shows two large calcified intracranial lesions that extend into the brain substance. This patient has encephalotrigeminal angiomatosis or Sturge-Weber syndrome. The skin lesions, often termed nevus flammeus, are most often found in an area innervated by one or more branches of the trigeminal nerve. The area supplied by the ophthalmic division of the trigeminal nerve is most often affected, and in such instances the upper eyelid is always involved. The facial angioma is generally unilateral, is present at birth, and does not enlarge during lifetime. The cerebral lesions are believed to be multiple venous aneurysms in the meningeal sheaths that become calcified and extend into the brain. The major ocular lesions include congenital glaucoma, always on the side of the facial angioma, and diffuse, flat, choroidal hemangiomas, as in this patient. The etiology of the glaucoma is unknown. In some cases, a true congenital glaucoma is present, with anterior insertion of the longitudinal ciliary muscle and incomplete cleavage of the chamber angle. In other cases, extensive choroidal and ciliary body hemangiomas have been found that result in an increase in episcleral venous pressure with secondary glaucoma. Slide 87. Encephalotrigeminal angiomatosis. This 24-year-old female was seen for routine eye examination. Upper left, during the examination, it was noted that the patient had extensive makeup covering her left forehead and temple. Upper right, after the makeup is removed, a large facial angioma in the region supplied by the ophthalmic branch of the trigeminal nerve is evident. Lower left and lower right. In another patient with encephalotrigeminal angiomatosis, the eye examination was normal except for the posterior pole of both eyes. The right optic disc is mildly elevated with a blurred margin and central hyperemia. A fluorescein angiogram demonstrated no disc leakage. The left optic disc is flat, with a normal central cup. The circumpapillary region has a uniformly dusky red appearance. Both of these eyes may contain angiomatous lesions associated with the Sturge-Weber syndrome. The right eye probably has some type of intrinsic optic disc angioma, while the reddish appearance of the fundus in the left eye is almost certainly due to a diffuse choroidal hemangioma. Slide 88. Retinal and cerebellar angiomatosis. This 32-year-old female gave a 3-month history of difficulty with her balance. Visual acuity was 20/20 OU with full visual fields. There was some nystagmus in all positions of gaze. Upper left, upper right, and lower left. Multiple red lesions of various sizes are seen in both eyes. Each lesion has at least one feeding artery and one draining vein. Lower right. An ME scan shows a large, circumscribed lesion in the right cerebellar hemisphere. At craniotomy, this proved to be a solid hemangioblastoma. This patient has the syndrome of retinal and cerebellar angiomatosis, or von Hippel-Landau disease. The retinal lesions begin as small endothelial cell rests and may appear at any age, usually during childhood or adolescence. The lesions may occur anywhere in the fundus and may involve the optic nerve. According to Landau, 25% of patients with retinal angiomas have neurologic symptoms, but no pathologic studies have confirmed this observation. The cerebellar hemangioblastomas are true tumors and should be searched for and removed in any patient with retinal angiomas, whether or not the patient is symptomatic. Conversely, patients in whom cerebellar hemangioblastomas are present should undergo careful ophthalmoscopic evaluation for retinal angiomas. In addition, since this disorder is transmitted as an autosomal dominant, all family members of patients with retinal angiomas should have periodic fundus evaluations. The von Hippel-Landau syndrome is the only one of the phacomatoses in which there are no associated skin lesions. For this reason, the diagnosis is based entirely on ophthalmoscopic examination. Slide 89. Unilateral retinocephalic arteriovenous malformations. This 9-year-old female was found to have decreased vision in the right eye 3 years previously. Recently, she developed increasing lethargy, headaches, and a mild right hemiparesis. Upper left. The right optic disc is obscured by a network of enlarged abnormal vessels that extend into peripheral retina. Upper right. A fluorescein angiogram shows extensive arteriovenous communication, but no dye leakage. Lower left. An ME scan shows moderate hydrocephalus. In the region of the left thalamus, a large mass extends into the left lateral ventricle. Lower right. A cerebral angiogram demonstrates a large vascular malformation fed by both middle cerebral and posterior cerebral circulations. This patient has unilateral retinocephalic arteriovenous malformations, or Wyburn-Mason syndrome, a disorder that includes racemose arteriovenous malformation of the retina associated with arteriovenous malformations of 1. The orbit, 2. The optic nerve, optic chiasm, or both, 3. The ipsilateral maxilla, mandible, and pterygoid fossa, 4. The ipsilateral basal frontal area, and 5. The posterior fossa and midbrain. Patients with these arteriovenous malformations may have normal or decreased vision. We believe that patients with retinal arteriovenous malformations, even if asymptomatic, should have an EMI scan to determine if there is a silent intracranial AV malformation present. In addition, patients with retinal arteriovenous malformations should be warned against tooth extraction, since such a procedure may be accompanied by severe arterial hemorrhage. In this condition, the intracranial lesions are arteriovenous malformations and not hemangioblastomas, as in the von Hippel-Landau syndrome. Neurosurgical intervention should not be undertaken unless there are severe, recurrent neurological signs and symptoms. Slide 90. Pigmentary retinopathy. Diffuse abnormalities in the retina and retinal pigment epithelium occur in a variety of neurological conditions. Upper left and upper right. This 1 1/2-year-old male was noted to have nystagmus since birth. He was otherwise healthy. He followed light with either eye, but would not follow small objects. His pupils reacted sluggishly to light, and a horizontal nystagmus was present in all positions of gaze. The right optic disc is normal, but the retinal arteries are attenuated. The macula has pigmentary changes. The peripheral fundus has a blonde appearance, and there is pigment migration into the retina. An electroretinogram was extinguished in both eyes. This child has Leber's tapetoretinal degeneration, or Leber's congenital amaurosis, an abiotrophy of the retina and retinal pigment epithelium. Most affected children are otherwise normal and present with nystagmus and poor vision, although a small percentage of patients have neurological or renal abnormalities. In the early stages of the disease, the patient's pupils are sluggish, but the fundi are normal. As the disease progresses, the retinal vessels become attenuated and pigmentary retinopathy occurs. This disorder should be suspected in any child with nystagmus and poor vision with or without pigmentary retinopathy. An extinguished electroretinogram confirms the diagnosis. There is no treatment for this disorder. Lower left and lower right. This 10-year-old male was in good health until age 6, when he began to have difficulty walking with a tendency to stagger. Over the next 4 years, he became uncoordinated and developed difficulty with speech. At age 10, he was found to have visual acuity of 20/70 OU and horizontal nystagmus. A general examination revealed pes cavus, severe ataxia with loss of both position and vibratory sense, and diminished deep tendon reflexes. The left fundus shows mild optic disc pallor, narrowed retinal vessels, and extensive pigment migration into the retina in a bone spicule pattern. This patient has Friedreich's ataxia, a dominantly inherited disorder that is the principal hereditary ataxia that occurs in children. Recognition of the associated pigmentary retinopathy may help to differentiate this disease from other causes of childhood ataxia. Slide 91. Chronic progressive external ophthalmoplegia and pigmentary retinopathy. This 15-year-old female noticed slowly progressive drooping of both eyelids. She complained of reduced night vision but denied double vision. Visual acuity was 20/25 OU, color vision was reduced, and visual fields were normal. Upper left. There is bilateral ptosis, and the patient's face seems flaccid. Upper right. On attempted left lateral gaze, ocular motility is severely limited in both eyes. Further examination revealed that extraocular movements were symmetrically limited in all fields of gaze. Lower left. Diffuse modeling of the retinal pigment epithelium, seen here in the left macula, was present throughout both fundi. Lower right, a muscle biopsy from a similar patient demonstrates an abnormal muscle fiber that stains darkly with succinate dehydrogenase. Chronic progressive external ophthalmoplegia, or CPEO, is a disorder characterized by progressive symmetrical ptosis and varying degrees of ophthalmoplegia. It may begin at any age, but usually occurs in adolescence. It is unclear whether this entity is primarily a myopathic or a neuropathic disorder, since patients with the disease may show features common to either or both. In these patients, biopsy of clinically uninvolved limb muscles often shows abnormal muscle fibers containing clusters of mitochondria and an abnormal amount of lipid material. These fibers have been called ragged red fibers because of their specific staining properties. In some patients, CPEO has been associated with a pigmentary retinopathy that may be progressive or stable. A triad of chronic progressive external ophthalmoplegia, pigmentary retinopathy, and heart block has been described as the Kearns-Sayre syndrome. Although there is no treatment for this disorder, it is important to make the correct diagnosis, since the cardiac abnormalities, if detected in time, can be managed with medical therapy or with a cardiac pacemaker. Many authors believe that the entity known as chronic progressive external ophthalmoplegia actually represents a number of different degenerative disorders whose common denominator is ophthalmoplegia and ptosis, but whose etiologies differ. Slide 92, subacute sclerosing panencephalitis. This 13-year-old female complained of decreased vision in her right eye. Visual acuity was 20/40 right eye and 20/20 left eye. She was otherwise healthy. Upper left, the right macula shows numerous retinal pigment epithelial abnormalities. 2 months later, the patient became confused and disoriented and began having seizures. She was unable to talk coherently. Serologic tests demonstrated a high titer of measles virus antibody. Upper right, brain biopsy from another patient shows a lymphocytic and plasma cell infiltration of brain substance. The arrow points to an eosinophilic intranuclear inclusion body. Lower left and lower right. The retina shows extensive atrophy and disorganization of all layers, with infiltration by mononuclear cells and intranuclear and intracytoplasmic eosinophilic inclusion bodies. Subacute sclerosing panencephalitis, or SSPE, results from infection of the central nervous system by the measles virus. It most commonly occurs in children and is characterized by intellectual deterioration, inappropriate behavior, seizures, and myoclonus. The diagnosis is confirmed by the identification of eosinophilic intranuclear and intracytoplasmic inclusion bodies that represent the viral particles. Ophthalmoscopic findings in patients with SSPE include papilledema, papillitis, optic atrophy, and both macular and peripheral retinochoroiditis. Although the retinal lesions often appear after neurologic manifestations of the disease, they may also occur months before the development of any neurological abnormalities as the first sign of this disorder. Slide 93, the sphingolipidoses. The final group of diseases that we discuss are the inborn errors of lipid metabolism that are transmitted as autosomal recessives. Upper left. The patient is a 1-year-old Jewish male who was normal until age 10 months when he became increasingly lethargic and did not appear to notice his surroundings. The left optic disc is normal. An opaque white retina surrounds the dark red fovea. The patient developed progressive generalized muscular weakness and died 6 months later from a respiratory infection. Upper right. A histologic section of the macula in a similar patient shows ballooning of retinal ganglion cells by a dense material that stains positively for lipid. The retina is otherwise normal. This patient has Tay-Sachs disease, or GM2 type 1 gangliosidosis, a disorder characterized by progressive mental and physical deterioration ending in death. Patients with this disorder have a deficiency of the enzyme hexosaminidase A in all cells of the body. In the retina, the deficiency causes accumulation of lipid in the retinal ganglion cells. Because of the large number of ganglion cells in the macula, this region appears white, and the resultant opacification increases the contrast between the fovea, which is free of ganglion cells and normal in appearance, and the surrounding opacified retina. It is, therefore, not the cherry red spot that is abnormal, but the surrounding retina. Lower left. This 13-year-old male was well until 1 year previously, when he began to develop progressive mental deterioration, convulsions, and myoclonus. He recently began to have visual difficulties. Visual acuity was approximately 20/80 OU. The right optic disc is normal. The macula shows extensive pigment abnormality in a bullseye pattern. Lower right. The patient died 6 months later. The retina shows extensive loss of both neuroepithelium and pigment epithelium. The inner retinal layers are intact, but the photoreceptors are atrophic, and there is migration of pigment into the retina. Also called Batten's disease, neuronal ceroid lipofuscinosis is another inherited disorder of lipid metabolism. It usually occurs in children and is characterized by psychomotor deterioration, convulsions, and retinal degeneration. Unlike the patients with Tay-Sachs disease, patients with Batten's disease have a granular pigmentary degeneration of the macula that often has a bullseye appearance. In some patients, only a peripheral pigmentary retinopathy with attenuated vessels is observed. Because of the extensive destruction of the retinal pigment epithelium and photoreceptor layers, an electroretinogram in patients with this disorder is abnormal, distinguishing it from Tay-Sachs disease and other gangliosidosis. The finding of a pigmentary macular degeneration in a patient with central nervous system deterioration may help to establish the correct diagnosis and aid in subsequent genetic counseling. You have now completed the text of the ocular fundus in neuro-ophthalmologic diagnosis. The next 7 slides will test your knowledge regarding this subject. A brief clinical history will be given for each slide. You will then be asked several questions. Write down your answers. After slide 100, return to slide 94 for a discussion of these cases. If you missed any, you may wish to review the appropriate section in the text. Slide 94, Quiz 1. This asymptomatic 45-year-old male was seen for a routine eye examination. Visual acuity was 20/25 OU, and color vision was normal bilaterally. The optic discs are shown above, and the visual fields below. What is the diagnosis? What further studies are needed? Slide 95, Quiz 2. This 68-year-old female complained of sudden visual loss in her right eye. A similar loss of vision occurred 2 months ago in her left eye. Visual acuity is 2200 right eye and 2400 left eye. Color vision is abnormal bilaterally, and there is a left afferent pupillary defect. The optic discs are shown above, and the visual fields below. What further studies are indicated? What is the probable diagnosis? How would you treat this patient? Slide 96, Quiz 3. This 25-year-old female experienced sudden loss of vision in her left eye. Visual acuity is 20/20 right eye and 20/40 left eye. Color vision is defective in the left eye, and there is a left afferent pupillary defect. The optic discs are shown above, and the visual fields below. What further studies are indicated? What is the probable diagnosis? What treatment is indicated? What is the patient's visual and systemic prognosis? Slide 97, Quiz 4. This slide shows the fundi of 2 35-year-old females with headaches. In both patients, visual acuity is 20/20 OU with normal color vision and enlarged blind spots. What is the ophthalmoscopic diagnosis in each patient? What studies are indicated in each patient? Consider how the management of each patient would vary depending on the findings of the studies that you have suggested. Slide 98, Quiz 5. 2 years ago, this 18-year-old male had a normal eye examination. He now complains of progressive loss of vision in his right eye. The right eye has light perception vision and an afferent pupillary defect. The left eye has visual acuity of 20/20 with normal color vision. The optic discs are shown above and the visual fields below. Where is the lesion that is responsible for this patient's visual difficulties? What are 3 common etiologies? What further studies are indicated? Slide 99, Quiz 6. This 23-year-old female recently noted blurred vision in her left eye. Visual acuity right eye is 20/20. Visual acuity left eye is 20/25. Color vision is normal in both eyes, and there is no afferent pupillary defect. The left fundus is shown above, and the right optic disc and macula are shown lower left. The visual field of the left eye is shown lower right. What further studies are indicated? What is the probable diagnosis? What treatment is indicated? Slide 100, Quiz 7. This 12-year-old female has decreased vision with minimal proptosis of her right eye. The left eye is normal. What systemic condition is responsible for this patient's clinical picture? What is the probable cause of the patient's decreased vision and proptosis? How would you manage this patient? Now return to slide 94, and we will review the findings and answer the questions. Slide 94, Quiz 1. This patient has the tilted disc syndrome. Note that both discs have an exaggerated oval appearance owing to their extreme oblique entrance into the eye. This appearance should not be confused with papilledema. Although the patient's visual fields show bitemporal defects, the defects do not obey the vertical midline as would the defects in a true chiasmal syndrome. No further studies are needed in this asymptomatic patient with a bilateral optic disc anomaly. Slide 95, Quiz 2. This patient has bilateral anterior ischemic optic neuropathy. The patient's history of sudden visual loss and the findings of decreased visual acuity, defective color vision, and altitudinal field defects in both eyes is incompatible with the diagnosis of Foster-Kennedy syndrome. In this age group, ischemia is the most common cause of optic disc edema on one side and optic atrophy on the other. The major etiology to be considered here is giant cell arteritis. A careful history should be taken to determine if the patient has arthralgias, jaw pain, ear pain, or scalp tenderness. An erythrocyte sedimentation rate should be obtained, and, if the clinical situation warrants, a temporal artery biopsy should be performed. We do not advocate steroids for anterior ischemic optic neuropathy unless it is associated with giant cell arteritis. Slide 96, Quiz 3. This patient has unilateral anterior optic neuritis. The sudden onset, decreased visual acuity, defective color vision, and central scotoma are typical of the findings in this condition. A careful neurologic history and a baseline neurological examination should be obtained. We do not generally perform any other baseline tests, although some physicians obtain skull X-rays. In the absence of neurologic symptomatology, we do not advocate spinal fluid examination. There is no evidence that steroid therapy alters the eventual outcome of anterior optic neuritis. Accordingly, we prefer to follow these patients at regular intervals. Over 90% of patients with anterior optic neuritis recover normal or near normal visual acuity, color vision, and visual fields. According to Percy and co-workers, only 17% of patients in this age group who present with optic neuritis will eventually develop signs and symptoms of multiple sclerosis. Slide 97, Quiz 4. The patient shown above has bilateral optic disc edema. Note that the retinal vessels are obscured as they traverse the surface of the optic discs, and that the peripapillary retinal nerve fiber layer is blurred. This patient should be immediately hospitalized and should be worked up for a possible intracranial mass. Skull X-rays, computerized tomography, cerebral angiography, and pneumoencephalography may be required. If these studies demonstrate an intracranial mass or other structural abnormality, then treatment is directed toward the lesion. If no intracranial abnormality is found, a diagnosis of pseudotumor cerebri is made. The patient can then be followed at regular intervals unless severe headache or signs of optic nerve damage necessitate treatment. The patient shown below also has elevated optic discs. However, neither disc is hyperemic, and the retinal vessels are not obscured as they traverse the discs. The peripapillary retinal nerve fibrillaire is seen up to the disc margins. This patient has buried drusen of the optic disc. No further studies are indicated. Slide 98, Quiz 5. This patient has a chiasmal syndrome that has caused loss of vision in one eye and a small superior temporal field defect in the other eye. This condition occurs when the optic nerve is compressed as it enters the chiasm. The most probable etiologies in this age group are pituitary adenoma and craniopharyngioma. Meningioma and suprasellar aneurysm are less likely to cause this clinical picture. The patient's workup might include skull X-rays with views of the optic foramina, cella-turcica polytomography, computerized tomography, cerebral angiography, and possibly pneumoencephalography. Depending upon the nature of the lesion, removal can be accomplished through a craniotomy or a transsphenoidal approach. This patient had a large pituitary adenoma that was completely removed. Slide 99, Quiz 6. This patient has papillophlebitis. The fundus picture resembles a central retinal vein occlusion with dilated retinal veins, superficial hemorrhages, and cotton wool spots. The patient should have a general medical evaluation, including a complete blood count and a serum protein electrophoresis, to rule out such systemic diseases as hypertension, multiple myeloma, or Waldenstrom's macroglobulinemia. However, most patients with this condition are young and healthy and have no systemic abnormalities. The visual and ophthalmoscopic prognosis is excellent without treatment. Slide 100, Quiz 7. This patient has von Recklinghausen's neurofibromatosis. Upper left shows the iris nevi that occur in this condition. Classical skin lesions in neurofibromatosis, shown upper right, are café au lait hyperpigmented skin patches. The most common cause of proptosis, disc edema, and visual loss in children with neurofibromatosis is an optic nerve glioma. Since this lesion is a benign hamartoma, we would favor observation of this patient rather than orbital exploration and removal of the tumor, although we would not quarrel with orbital exploration and biopsy of the optic nerve to rule out an optic nerve sheath meningioma. It should be remembered, however, that some patients with optic nerve gliomas have normal or near normal visual acuity. In such patients, we would never biopsy or resect the optic nerve. The self-evaluation quiz was provided to assess your knowledge of the diagnosis and management of patients with neuro-ophthalmological disorders that are associated with abnormal fundi. You may use other slides in this series in a similar self-evaluation by making your diagnosis before listening to or reading the descriptive material.